Okay. Marine, just check the YouTube also. It'll take about 20 seconds. 20 seconds.
Yeah. I'll just let you know now.
Yeah, yeah. Siju illa. Siju അവിടെ എല്ലാം കോവിഡ് ആയിട്ടിരിക്കുക. സെക്കൻഡ് റൗണ്ട്.
ഇവിടെ വീട്ടിലിരിക്കാമല്ലോ.
സിജുവിന്റെ വീട്ടിലുണ്ട്.
വീട്ടിലിരുന്നോണ്ട് കോ ഹോസ്റ്റ് ആവാൻ പറഞ്ഞാൽ മതി. കോവിഡ് ആവുമ്പോ സമയം കളയാൻ ബെസ്റ്റ് സമയം ഇതാണ്. പ്രോഗ്രാം കേട്ടോണ്ടിരുന്നാ മതി.
Ma'am, am I audible now, ma'am?
Yeah. You are audible now.
Now you are audible. Yeah.
1 minute more. Arun.
Yes, sir.
Okay, Arun, we'll start.
Okay. Good morning, ladies and gentlemen. Welcome to the Cochin Ophthalmic Club Super Sunday series of 2022. We are starting off with the first being the Orbit and Oculoplasty Super Sunday series. I'm Dr. Thomas Arun Verghese, Secretary, Cochin Ophthalmic Club. I now hand over to our President, Cochin Ophthalmic Club, Dr. S. Shashikumar. Over to you, sir.
Thank you, Arun. Good morning, everybody, and welcome to the PG program of Cochin Ophthalmic Club. As you know, Cochin Ophthalmic Club is one of the most active ophthalmic fraternity during this COVID era in Kerala. We have had the Dr. Noel Moni's lecture on January 23rd. It was well accepted by in and outside Kerala. And this is a series of postgraduate education program that the Cochin Ophthalmic Club have planned. And actually this was started by the previous team of office bearers. We are continuing with that. This is called Super Sunday. And today the topic is oculoplasty, in which all the basic topics of ptosis, proptosis, thyroid eye disease, entropion, ectropion, socket tissues, all will be discussed by an excellent galaxy of experts in the field. And actually the postgraduates are very fortunate to have such subject experts to teach you on this topic. February 4th was the World Cancer Day. And in connection with that, well-known ocular oncologist, Dr. Fairuz, will be giving the World Cancer Day lecture on lid rumors. The official newsletter of Cochin Ophthalmic Club, called the Cocktails, will be published monthly from now onwards. It will reach you all in a digital format, and it will have academic as well as non-academic content with some features for infotainment also. And the first of this will be released today. We are planning activities for the glaucoma week also, and the August Ophthalmica, which will be held on August 14th, The planning for that also have started from our side. I also request all of you to watch the program on substance abuse for the public by Kerala Society of Ophthalmic Surgeons today, this evening. And with these few words, I inaugurate this Super Sunday program for the postgraduates. And I will release the newsletter. I'll share the screen. Is it visible now?
No, no, sir.
Is it visible now?
Yes, sir. Yes, sir.
So the cocktails, the first issue is being released today, and I take this opportunity to congratulate our young editorial team of Dr. Lakshmi and Dr. Karthika Mohandas, and which is there is a expert veteran team that support them. Dr. Verma, Dr. Surabha, Sunil, Dr. Natasha, all of us are giving excellent support to this young editorial team, and this will come as a flip book format like this, and it will have all our activities. The monthly report will be there. And this will be released every month from now onwards. And with these few words, I hand over the proceedings to Dr. Marian, who is the Scientific Committee Chairman of Cochin Ophthalmic Club.
Yeah, thank you, sir. Good morning, all. I'm very happy to welcome you all to this Super Sunday CME organized for postgraduates by Cochin Ophthalmic Club. Actually, it was our dream to restart this Super Sunday program. Even though we have planned for physical wet labs and suturing workshops, the world has changed in a matter of weeks, so we need to go for virtual again. And hopefully in another 3 to 4 months' time, we can go for physical workshops and wet labs so that more of teaching for the postgraduates can happen. So today we are having a galaxy of faculty, and in fact, the postgraduates and residents are really fortunate to have such a star faculty teachers from different parts of India. I especially welcome our guest faculty from outside KSIS, Dr. Savri from Mumbai, Dr. Sonam from Chennai, Dr. Feroz from Bangalore, Dr. Sushma from Bangalore, and to this program. This program includes a basic evaluation of the base oculoplastic conditions like ptosis, proptosis, Ectropion, etc., followed by the basic management of the conditions. We have formulated the program primarily to help the residents to write the exam as well as for practicals. And in order to increase the knowledge, we have put one instrument corner where various instruments used in plasty has been discussed, as well as a rapid fire quiz, which gives an overall view of the orbit and oculoplasty. With this few words, I invite Dr. Shevin. She is the consultant oculoplastic surgeon at Giridhar Eye Institute, Kochi. And she did fellowship from Shankar Nethralaya and currently working with me. I hand over to Dr. Shevin to moderate the whole session. We are planning the session from 9 to 1:30. Hope we will be able to cover the important topics in this short duration of time, even though it is little difficult because we know all the plastic procedures are little long procedures, and each has its own steps, and each surgery has its own complications, unlike the other specialities. And we have got 3 areas: lid, lacrimal, socket, and orbit. Oncology we have not included in this because we already had an oncology Super Sunday in association with the last year's World Cancer Day. So now I hand over to Dr. Shebin to start the session. Over to Dr. Shebin, please.
Thank you, ma'am. A very good morning to all. It was such a pleasure to be part of this program. So let me share the screen. I hope my screen is visible.
Yes, Shebin.
Okay. So the first topic is on evaluation of proptosis by Dr. Anne Schecker. She is a consultant ophthalmologist, and at present she is working in Little Flower Hospital, Ankamali. Good morning to ma'am. And can you please share your slides? I will stop sharing.
Is my screen visible?
Not yet, ma'am.
Sorry, let's see. Is it visible now?
It is still not visible. So multiple participants can share the screen.
Yeah.
Yeah, it's visible now, ma'am.
Okay.
We have to go to the slideshow now. Yeah.
Okay. Thank you, Dr. Shebin, and thank you, COC, for giving me this chance. And my topic is evaluation of proptosis. So proptosis, as all of you know, it is the abnormal protrusion of the eyeball. Another terminology is exophthalmos. We commonly use for thyroid ophthalmopathy. Exophthalmometry is the measurement of proptosis, that is the distance from the lateral orbital rim to the corneal apex. And it varies with age and ethnicity. In average Indian population, the upper limit is taken as 20 millimeters. And relative proptosis if the asymmetry between two eyes is more than 2 millimeters. It is classified as mild, moderate, and severe. Another classification is axial. In the first picture, you can see the left eye is displaced forwards. The displacement is purely forwards. That means it is axial. It is due to any intracorneal lesions. The second picture shows non-axial displacement, also known as eccentric or abaxial proptosis. Here the eye is displaced towards anteriorly and also laterally. Another entity is pseudoproptosis. So there are conditions which simulate proptosis, but there is no proptosis. Conditions are ipsilateral enlargement of globe, as in myopia, ipsilateral retraction in conditions like thyroid ophthalmopathy, contralateral in ophthalmos, ptosis, facial asymmetry, and shallow orbits in case of craniosynostosis. So such things you have to keep in mind before jumping into diagnosis. A simple method to assess proptosis is to look from patient from above and behind while patient is sitting on a chair. And if you see either of the eye is prominent, that means this eye has proptosis. So you can see in this picture that left eye is proptosed. Another method is worm's eye view, and ask the patient to gently extend his head for about 45 degrees and view from the front. So here also you can see the prominence of left eye. And there are certain lesions specific for some age group. So the knowledge of this will help you to narrow down your diagnosis. So that differential diagnosis you can take into consideration. So in infants, it is more in capillary hemangioma, encephalocele, microphthalmia with cyst. But in childhood, it is lymphangioma, rhabdomyosarcoma, etc. In adults, it becomes thyroid ophthalmopathy. So the most common cause of unilateral or bilateral proptosis is thyroid ophthalmopathy. And about duration and onset, if it is abrupt in onset, the cause may be trauma or any infections. But if it is days or weeks, you have to think about inflammatory etiology. And in neoplastic lesions, either malignant or benign, it will be months or years. And there is a condition known as intermittent proptosis. That means sometimes there is proptosis, sometimes there is not. This condition occurs in orbital varices, where the varices get filled up with blood, the orbital venous pressure increases, and this causes the forward displacement of the eye. So in this picture, you can see orbital varices. And while taking history, ask about pain. Pain is seen in trauma, infections, inflammations, etc. And visual loss, if there is any pressure over the optic nerve, or if there is splinting of the optic nerve, as in optic nerve sheath meningioma, or any mass is compressing the posterior pole of the eye, causing the choroidal folds. Such conditions, you can see visual loss. And also in exposure keratopathy. Double vision can be there due to mass effect of the globe, or any neurological problems, or any muscle problems, like in thyroid ophthalmopathy, or there can be impingement of the muscles in the fracture site, etc. And ask about trauma, thyroid dysfunction, sinus infections, systemic malignancies, and also increase in protrusion with upper respiratory tract infection. This condition is seen in lymphangioma. Like all other ophthalmology examination, you have to do best corrected visual acuity measurement, see the facial symmetry, ocular movements, whether it is full or restricted, and also the direction of the proptosis. This gives an important clue about the etiology. So in this patient, you can see the right eye has axial proptosis, and the imaging shows there is a retrobulbar mass that is in the intracornal compartment. That means in between the recti muscles. So any intracornal mass can cause axial proptosis. The most common cause of axial proptosis is thyroid ophthalmopathy. Others are optic nerve tumors like glioma, meningioma, etc. In this lady, you can see the eyeball is displaced down. So something in the superior orbit might have caused this. In this case, it is lacrimal gland tumor. Here again, it is pushed laterally. So any medial tumors like sinus mucoceles, this patient is having frontoethmoidal mucocele. And here the eyeball is shifted up. So you can see a mass in the maxillary sinus. So if you know the structures in and around the orbit, you can narrow down your diagnosis. And our examination of proptosis goes in this sequence: inspection, palpation, and auscultation. So always look for the lid signs. All of you know about thyroid ophthalmopathy signs. I am not going into detail. Sometimes proptosis can coexist with ptosis. So you have to suspect myasthenia gravis along with thyroid ophthalmopathy, because these are both are autoimmune conditions that can coexist. And S-shaped ptosis you can see in neurofibromatosis. Facial asymmetry you have to look for, and also the color of the lids. If it is bluish in color, there are more chances of having lymphangioma or orbital varices, ecchymosis in leukemia and metastatic neuroblastoma. And look for pulsations. Pulsations can be both CSF pulsations or arteriolar pulsations. So if there is any dehiscence in the superior wall of the orbit, as in trauma or in neurofibromatosis, you can have pulsating proptosis. And if there is arteriovenous communication like aorticocavernous fistula or AV malformation, you have vascular pulsations. And fullness of temporal fossa you can see in sphenoid wing meningioma. And palpation, look for the resistance to retropulsion. You have to use your thumb and just apply pressure and see whether any resistance is there. If it is there, that means there is a solid tumor behind. Otherwise, it can be vascular. Look for pulsations and thrill. Thrill you can see in vascular lesions, not in CSF pulsations. Orbital margins you have to palpate. Look for any step deformity or fossa formation due to long-standing lesions. like pleomorphic adenoma. And sensations, of course, some of the tumors can cause altered sensation, as in adenocarcinoma, perineural invasion can cause altered sensation. And if there is any mass in the anterior orbit, you have to mention its location, size, shape, borders, whether the posterior border is palpable or not. Ask the patient to look into the direction of the mass so that it can relax the septum, and whether it is tender or not. Palpate the regional lymph nodes. Those are preauricular, submandibular, and anterior cervical. And look for PNS tenderness and also thyroid gland. Auscultation is done with the bell of the stethoscope. Ask the patient to close the eye and put your steth over there, and you can see bruit. You can hear bruit. Coming to exophthalmometry, it differentiates between true and pseudo proptosis and also help to monitor the progression of the disease and the outcome of your treatment. There are different types of exophthalmometers. We commonly use Hertel's and Lutz exophthalmometer. So this is a Hertel's exophthalmometer. You can see there are two foot plates and there is a crossbar, and this foot plates host to a system of mirrors also. So this is a short video of this Hertel's exophthalmometry. The patient has to sit at the eye level of the examiners. Both should be same, and it is good to have an overhead lamp so that you can see the corneal reflex clearly. And place the exophthalmometer over patient's face, and that there is a arched groove at the posterior part, so that has to fit in the deep part of the temporal orbit. And ask the patient to look straight. And there are two red markings you can see inside this mirror here, and so that has to be coinciding. You have to superimpose that, otherwise there will be parallax. And look for the corneal reflex on both sides, that also appear in the mirror. And the same time you have to look for the crossbar readings to record the interorbital distance. So that measurement you have to keep for further monitoring of this patient. It has to be constant. So what you see is like this. Here you can see the corneal reflex in the mirror, and the reading is approximately 14. And this is the red marking which I have told earlier. So this is in a single because it is superimposed. And also see the crossbar reading. So here it is around 94. So how do you write it? So this is the crossbar reading. Conventionally, we write the right eye reading above and left eye reading below. So suppose if it is 16 in left eye, then you will say that left eye is 2 millimeter proptosis is there. Another exophthalmometer is Lutz exophthalmometer. This is a transparent scale with readings on both sides, and it has got a notch. That notch has to fit into the lateral orbital rim and make the hold it in such a way that the readings are superimposing. So there is no parallax, and look for the corneal reflex. So in this case, you can measure only one eye at a time. And both these exophthalmometers, we use lateral orbital rim as the reference point. What if it is not intact due to trauma or due to any decompression surgeries and all? So another instrument is Nogel's exophthalmometer. Here you need not have an intact lateral orbital rim. You can place it, here the reference point is superior and inferior orbital rims. Radiological method, you have to take a CT scan in the axial view when the lens is clearly visible. And you can draw a line connecting two lateral orbital rings and a perpendicular towards the corneal apex and compare the length. So you can get the proptosis measurement if it is there. So far we were talking about axial displacement. This is how will you measure non-axial displacement? There is a special instrument known as McCoy facial tri-square. This is not commonly used. What we use is a simple ruler. So hold it like this and select a midpoint, and you can measure the displacement of the medial limbus from here and compare the results. And if the patient is having displacement in the vertical meridian, you can add one more scale and look for a reference point like inferior limbus also. And ask the patient to do Valsalva maneuver or ask him to bend down and with the head in dependent position for a few seconds, 30 seconds. Then you can elicit intermittent proptosis if it is there. Slit lamp examination, there are some special signs here there is corkscrewing of conjunctival and episcleral vessels due to high blood flow in a case of caroticocavernous fistula. And down this picture is salmon patch in a case of lymphoma. And cornea, you look for exposure keratitis. You have to stain and see. Iris, lesion nodules in neurofibromatosis. Fundus also you have to see for any disc edema, disc pallor, or opticociliary shunts, or venous dilatation, tortuosity, etc. And measurement of intraocular pressure is also important. And other systems has to be examined depending on the case, which is relevant to this proptosis examination. Thank you for your patient listening.
Thank you, ma'am. That was such a really nice class. It was all the points of proptosis evaluation are covered in detail and very beautifully. And we are well ahead of time also. And I think no questions from the PG side. Dear students, if you have any doubts, please share it on the YouTube platform so that we can clear the doubts, if any. So, ma'am, you have any concluding remarks, any advice to the PGs?
Yeah, regarding proptosis evaluation, the common mistake, most of the time, many of the hospitals are not having this Hertz exophthalmometer. So they use this two ruler method.
Yes.
Yeah, Dr. Ann, would you?
That due to the shortage of time, I couldn't
Yeah.
use tell it
Can you just
properly.
highlight?
So you can to know the what do you mean for abaxial displacement? You are saying?
Yes, yes.
Yeah, with the
And you can stop screen sharing, please. We can see you. Yeah. Yeah.
Okay, you can hold a ruler in a horizontal manner over the nasion. You can put it. I have shown in my slide. So, and any midpoint you have to take, like nasion or something. And from there, you have to measure the distance of the medial limbus and compare the horizontal displacement. If it is more on that side, means that eye is laterally displaced or medially displaced. And you can add on one more scale. Vertically in case of dystopia, that is if it is going down or up, and again you have to take a reference point, inferior or superior limbus, and compare from both sides, so that you can make how much it is displaced from the midline.
Proptosis with the squint, any take-home messages? With
proptosis, yeah, you have to make the squinting eye fixing, then you can take the fixation. You can close the other eye and check, and if it is not possible, if the eye is not taking fixation, then the most prominent part of the globe you have to take. That's the available option.
If the lateral wall is absent, you can take superior orbital rim as a reference point also.
Yeah, superior and inferior orbital rim you can take. There are some special exophthalmometer which we don't use it commonly.
Dr. Shevin, Dr. Savary, anybody wants to add anything to this proptosis evaluation?
Yes, ma'am. In one-night patients, sometimes they don't do the proptosis evaluation. So we can do it with the prosthetic eye in place if it is in the proper, if the volume is properly replaced. But otherwise, we can. Any comments on that, ma'am?
No, we can do with the prosthesis. if the prosthesis is ortho, it's very easy to take. If the prosthesis is displaced, like ESO or EXO, probably a little difficult, but you can get a relative measurement. This is very, very important when you assess the orbital volume, like, how much in ophthalmos, how much, and to plan the management, it's very, very important.
And also we can take like measurement only on the normal side alone, and can see how much is, if it is more than 21 or not.
Yeah,
so
I
relate
can compare it with the standard value.
Yeah. Okay, thank you, ma'am.
Thank you.
Thank you, Anne.
So so shall we go to the next lecture? Hope my slide is again visible.
Yes, yes.
Okay. Now our next topic is lecture is by Dr. Savri Desai. So she's a consultant at Department of Ophthalmic Plastic Surgery at PD Hinduja Hospital, Mumbai. She's the current treasurer of OPI, and she completed her fellowship in oculoplasty from LV Prasad Eye Institute, Hyderabad. She has multiple awards and multiple papers on her behalf. So I welcome Dr. Savri. To you, ma'am.
Thank you, Shebin. Marian and actually I go a long way back when we finished oculoplasty and we had our first conference in Mumbai, and she was a really enthusiastic post fellow thing, and it comes a full circle when you're doing this for your students, Marian. So it's wonderful. Thank you, Cochin Ophthalmic Club, and thanks to you. And I'm always love teaching students, and we also have our own residents, who make a big part and parcel of how we grow and learn. So please stop me if I go over time, Shebin, and maybe you can just let me know 10 minutes. So sure. Let me share screen. So my topic is to simplify orbital approaches. Is that seen?
Yes, ma'am, it is seen. Okay. Yeah.
Right. So orbital surgical approaches, this diagram I really like. It tells you all the sort of approaches that are there, and those are the different names. So whoever described any new incision named it. So it's kind of mind-boggling, a bit like remembering thyroid eye disease 25 times and their names. But in thyroid eye disease, unfortunately for your exams, some examiners like you to name a couple with their names. I don't think it's really expected in practical, but in theory, you may need to know the ones which you commonly see, which we'll come to, which are either done in your parent institute or you may have read or seen. So, sorry. Okay. So coming to the most simple one, which is what we all learn, and literally I've taken this off one of the UG books, which is the 5 spaces, which is extracornal space outside the extraocular muscles, the intracornal space inside the extraocular muscles, the subperiosteal space, which is just below the periosteum, and of course the subtenon space. There is one more space, which is the subarachnoid space, which is just below the meningeal sheath, which is not mentioned. This is something that we commonly see, and we kind of, just mug up and say, okay, this is it. But what we are here to do is to try and simplify this whole process for you all. So the next quadrant that you really need to know when you look at an orbit like this is to know the quadrants and basically the simple walls. So if you divide it, it's divided into 4 quadrants: superonasal, superotemporal, inferonasal, inferotemporal. Very simply put, this is your eyeball. But further, you can divide it if you're looking at it sagittally or axially. So this is a sagittal view through the sagittal suture. This is the axial view. So if you're looking at it in any of these directions, it gets divided into an anterior orbit, which involves, of course, the eyelids, the lacrimal apparatus, also the palpebral of the lacrimal gland, and anterior, or what we call as preseptum. Then you have the posterior orbit. So posterior orbit margin is usually anything that's behind the globe. So as you've seen in both dimensions are shown here. So here is all these retroauricular tissues, which is the nerves, muscles. And actually this compartment can be also divided into intracornal, extracornal, subtenon, subarachnoid. But let's just forget that for now and just stick to this. So Rootman actually classified orbital approaches, which I used to think was simple and it still is, but I prefer to move away and kind of combine all of these. So an anterior approach, which is any lesion that's anterior. So simply put, it's through the skin or through the conjunctiva. So trans-skin or trans-conjunctival. And superiorly is again transfrontal or temporal frontal, which is going from like a ear-to-ear incision, which most of us know. Further, it's divided into a lateral approach and then a combined of any of these. So what does this all really mean when we put it together? So let's just break down Rootman's classification. What I tell my residents is, this is a good slide to know, especially if you get a 10-mark short note or you basically want to just have an overview to remember. And in this, you can further make a flow chart if you have a long question. And a lot of times you all are all getting now questions on oculoplasty, which have a lot of marks. So anterior are well-defined anterior lesions, usually involving such as dermoids, anterior 2/3 of the orbit, like we talked, the anterior part of the orbit. They can be either palpable or diffuse, mostly intraconal, extraconal space. So this is a diffuse lesion. So, or lacrimal gland lesion. So the incisions are usually taken along the natural eyelid contours. So such as subbrow, which will come to inferior ciliary. So these are some of the incisions we take. We're going through the skin now. So this is just upper lid crease. So let's give you examples. So upper lid crease, then subbrow incision, which was taken for this, such as this. Now this is a full one, but you don't need to always, you can take parts of this. Or you have subciliary incisions, which were taken for diffuse lesions, such as this. So these are the transcutaneous or going through the skin for mostly anterior 2/3 of the orbit. Then you have the anterior lesions, which are all transconjunctival. You can either go through medial perilimbal, or usually things like medial rectus, medial extraconal, subperiosteal, or lateral perilimbal, biopsies of lateral rectus. Transconjunctival further involves transcaruncular, which is almost like my favorite incision, which is again medial extraconal, the subperiosteal space. Of course, you don't get skin incisions and you can avoid the lacrimal sac. And another transconjunctival, which involves the inferior quadrant, which is again the inferior conjunctival. So trans anterior can be divided into, like just to recap, transcutaneous, transconjunctival, and these are the ones. Then come to lateral, which has got nothing to do with either, which there are different types where you take it in the lateral part of the eyelid involving the lateral rim. These can be coronal or Burkies. So we've moved, or even a modified called staladrite. So these are the three which you just need to know. There are further coronal incisions, which we talked about. We don't really do these very often, more neurosurgical approach. So let's simplify this. When we're looking at any orbital surgery, you need a surgical exposure, which is good. You need good, so you provide least trauma, collateral damage, and you have to provide cosmesis. And this is what we've put together, quadrants and divisions. So we talked about an eyelid crease. Eyelid crease, actually, if you go to see, covers superonasal, superotemporal, and a little bit of lateral. So you're covering all these quadrants, anterior and also posterior. Inferior fornicial covers the medial or the medial, inferonasal, and inferotemporal, again anterior and posterior. And transcaruncular, which can actually involves the superomedial little bit, but more inferomedial and medial, which you can again go to anterior and deep lesions. So this is something that combines all of them, and these are actually the lesions, incisions we really, or approaches we use. So deep medial orbit, another one is transcaruncular and endoscopic approach also, which we must know. So coming to a few examples, superior, superomedial, anterior, as you can see here, small dermoid, again another dermoid, these kind of lesions we can approach. So these are just very short 1-minute videos, because I feel sometimes seeing orients you. So this is the medial part, that's the well-defined dermoid, which is anterior. This is your eyelid crease, which is marked, and we are taking a eyelid crease incision. Now, it's not that it's too much for a PG person. It's just that sometimes you get better oriented when you're seeing surgeries, and these are just small clippings. There are many, many surgeries available on YouTube now with some of our colleagues who've done really good job. So we've done orbicularis dissection, and now we are directly on the lesion. But we haven't gone through the orbital septum. And just with blunt dissection, you can actually go right up to the periosteal plane. And you can see, so this is just dissecting it all around. This is your eyelid here. myelin margin, which we've not reached, the base of the dermoid, which is flush on the periosteum. So you've actually gone through an eyelid, through the orbicularis, and managed to reach the lesion. And using a cryogest for retraction, we have dissected it. So there was a very small periosteal attachment. So this is a eyelid crease incision for an anterior lesion, which is also, has a just on the periosteum. So this is now what we were talking was a medial lesion. Now let's come to the temporal lesion. So superior, anterior, or little deep, usually involving the lacrimal gland, can be also subperiosteal, such as abscesses. Okay, also can go deeper. So these kind of lesions. So let's see a small clipping again for this. Similarly, we have taken a marking. So we took an initial marking here. Now we are taking it laterally on the lid crease. So all these have different names. So now we've gone suborbicularis. This is something that we also do for ptosis. We go straight to the septum here, palpating the orbital rim, and now making an incision. So instead of doing a brow incision, which gives a scar, you can actually reach this area even through an eyelid crease incision. Once you reach the periosteum, as you've seen here, you made a periosteal incision, and you reflect the periosteum going into, reflect the arcus marginal, and then go into the periorbita and separate the periorbita. And you are sitting right on the lacrimal gland, which we have incised, and now we are taking a lacrimal gland incisional biopsy. But you can even do excisions of the lacrimal gland. You can go for lacrimal gland tumors. So this is a lateral eyelid crease, which has allowed us to go supero-temporally for anterior and deep lesions. So what about this? I'm going to skip. You can even do for thyroid decompression. So these are some of the lesions now for inferior. So fractures, such as this teardrop syncytial classical fracture, or large tripod fractures involving lateral and inferior fractures, or even the zygoma. Then large inferior lesions, or even small diffuse ones. So this entire thing in oculoplasty can go through inferior lesion. So instead of doing an inferior subciliary, we have to just do a transcaruncular lesion. An inferior fornicial lesion. So this is a approach we've used for a fracture, but it's very similar to this for any of the above indications. So that's the inferior fornicial marking. We've tagged the inferior rectus. That was also more to just keep it for teaching purposes also. So once we have done an inferior fornicial incision, so you do a subconjunctival dissection. So you go transseptal and you reach the inferior orbital rim, incise it, reflect it, and there we are, straight onto the floor. Now, if we don't want to go extraconal and you want to be intraconal, you don't need to incise it, and you can go directly to an intraconal lesion for a biopsy, such as incisional or excisional. So this is an inferior fornicial. Now I can extend from medial to lateral. So it gives you the inferomedial and the inferotemporal quadrant. And here is just going to continue to show you how we approach the fracture site. So how do we approach medial ones? So medial, either slightly anterior to mid-orbit or deeper lesions, can be approached to a transcaruncular. So this is a transcaruncular approach, short clipping, which was done for a medial wall decompression. So we've marked the transcaruncular. So use You can use these for medial rectus biopsies, for medial lesions, for inferomedial. They're very versatile and do really well. So once you made a transcaruncular incision, you do a subconjunctival dissection. That was palpating the posterior lacrimal crest. So this is for a medial decompression, but what I really want to show is, once we've dissected it, we actually are directly in the medial extracornal compartment, and that's what it is. This is the compartment. So you have the periosteum, the medial wall, the eyeball, the medial rectus, and you can easily access this. This is also often the route for optic nerve decompression. Medially endoscopic also for lesions of, say, the frontal sinus sometimes, such as this frontal ethmoidocele. So mucocele. So I'm not sure this is going to play, but this was one of the, so this is the approach we did endoscopically, and we went straight to the frontal sinus. As is seen here, you can see the probe going straight into the frontal sinus. That's your orbit. So the take-home message is that for a PG program, we need to localize this to a compartment as is traditionally shown to us. But it's also about combining everything and doing a different planning, and you have to know your anatomy. And when we're doing it for oculoplasty, we also always have a plan B in mind. Thank you.
Thank you so much, ma'am. That was really well explained. And of course, we need more time to understand everything in detail. Okay.
I made it just in time.
Yes, ma'am. Okay. And I think the questions can come, this approach to orbitotomy, both in theory and in practical, when you get a case of proptosis. And then the examiner can ask, like, how will you approach this case? So that time you will need all this in hand. We will need any questions to ask, Maria ma'am?
No, it was very, like, she has covered all at the PG level. Like, it's a capsule, surgical approaches to orbit. No need to read any textbooks now. Just listen to her. That's it. And I was literally, she was very, I mean, the students are very lucky to have you as a teacher. Thank you, Dr. Sagri. Yeah.
Thank you. Thank you.
Yeah.
That's very sweet of you. Thank you.
Yeah.
And thanks so
And thank
much.
you, like, for accepting our invitation at a short notice also. Thank you.
No,
so
no,
much.
come on, anytime.
Yeah,
Anytime. Thank you.
Thank you.
Thanks
Yeah,
both of
bye.
you.
Yeah.
Bye-bye.
Yeah.
Sorry. So let me introduce our next speaker. She's my dear friend also, Dr. Soumya Narayanan. Hope I am audible. Yeah. So she did her DNP and fellowship in orbit and oculoplasty from Dr. Agarwal Eye Hospital, Chennai. At present, she is working as a visiting oculoplastic surgeon at Al Salam Eye Hospital and Puttalata Eye Hospital, and also in Dr. Chandrakant Malabar Netralaya. To you, Dr. Soumya, she'll be talking on evaluation of ptosis.
Hope I'm audible and
Yes. Yeah.
Thank you, Dr. Marian ma'am and Dr. Shebin for this opportunity. The topic given to me is evaluation of blepharophimosis. So before going to the evaluation, we just quickly go through the basics. Blepharophimosis is defined as the inferior displacement of the upper lid below its normal position when the eye is in the primary position. There are mainly infantile and acute hyperptosis, and depending on the cause, we can divide into myogenic, neurogenic, mechanical, and traumatic. And to understand the abnormality, we should know what is normal. So when the patient comes, we should look for the eyebrow, the position of the eyebrow, whether it is at the level of the superior orbital rim or just above that, that is the normal position. You should look for the upper lid, whether it is at the 2 mm below the superior limbus, and the lower lid usually lies at the same level of the inferior limbus. and the horizontal palpebral fissure is usually 30 millimeters. The next important thing is the upper lid crease, which is formed by the LPS muscle. And when the patient is looking at the primary position, the muscle and skin at the upper lid crease will form the upper lid fold. And the distance from the upper lid margin to the upper lid crease forms the metatarsal space. And these are the elevators of upper lid, that is LPS, Frontalis muscle, and molars. And LPS aponeurosis forms some hooks to the skin and orbicularis occurred, which form the upper lid crease. And in history, we have to elicit the characters of the ptosis, like onset, duration, progression, and severity. Whether it is bilateral or unilateral, what are the associated features like diurnal variation, diplopia, dysphagia, any Marsden Joving phenomenon, whether the patient is having any general weakness. And the causes also like trauma, causes of the ptosis like trauma, surgery, any previous eye disease should be ruled out. So the examination of the ptosis starts as soon as the patient walks into our clinic, and also when he narrates the history. And then we should check for any frontalis overaction. What is the eyebrow level? Is there any excess skin? Whether the patient is having a very paper thin upper lid skin? What are the positions of the eye, upper lid and lower lid? Whether there is any growth or inflammation around the eye? The patient is having telecanthus or epicanthus. What is the direction of the lash? And also we should check whether the patient is having any abnormal head position, any strabismus, proptosis or anophthalmus. Whether the patient is having anophthalmia or microphthalmia. And now it's because of COVID, you should not miss any hemifacial atrophy or facial palsy because of the mask. And during our assessment, we should get answers to all these questions. Whether the patient is having a true ptosis or not, what is the type and severity of the ptosis, and what is the LPS action, so that we can plan what type of surgery we should do. Are we dealing with any life-threatening disease, and what are the prognostic factors? So these are the checklists. The patient and the doctor should be at the same eye level when evaluating. There should be the light source should be at the center of the nose, and the pupil should be undilated, and the eye should be orthophoric, and the frontalis muscle should be relaxed. So first question is whether the patient is having a true ptosis. So in that case, we should know what are the causes of pseudotosis. The most common one is the contralateral lid retraction, usually seen in thyroid eye disease. And we should also look for contralateral proptosis or ipsilateral anophthalmus. It can be detected with exophthalmometry. And a cover-uncover test will help us to find out any hypertropia or hypertropia. We should look for anophthalmia, microphthalmia, any superior surface deformity mimicking as ptosis, and for facial palsy. And these are the three situations where the it can coexist, and also it can come as alone also. In ptosis, there will be a drooping of the upper lid alone. In brotosis, there is a drooping of the brow below the normal position. It can associate with ptosis, or it can simply mimic as ptosis. And in the case of dermatochalasis, there will be excess upper lid skin, which can mimic as ptosis. And coming to the measurement, marginal reflex distance 1 is the most important one. That is the distance from the corneal reflex to the upper lid margin. This gives an idea about whether the patient is having true ptosis or not. MRD 2 is the distance from the reflex to the lower lid margin, and palpebral fissure height is the sum of it. And MRD 1 is usually 4 to 5 millimeters. So now we know that patient is having a ptosis. The next question is what type of ptosis we are dealing with, and how severe is the ptosis. If the patient is having a 2 millimeter droop, it is mild ptosis. 2 to 4 millimeters is moderate, and severe it is more than 4 millimeters. And marginal crease distance, that is a distance from the upper lid margin to the lid crease in the downward case, will give us an idea about what type of ptosis we are dealing. In aponeurotic ptosis, as the aponeurosis detaching and receding upward, the crease can be high, and there can be multiple lid creases. And in congenital case, the muscle itself is dystrophic, so there will be less muscle, there will be less fibers. So the crease can be either filled, or there can be no lid crease. And depth of the crease, especially in infants, is very important to assess, to give an idea about how is the LPS action. And we should see the level of ptosis in all cases of eye, especially the downward gaze. In case of aponeurosis, the total eye will be in a lower level than the normal eye. But in case of congenital ptosis, because of the muscle is neither contracting nor relaxing, it can have a higher level than the normal eye. We should also look for any markers when toe ringing. That is the improvement of the ptosis on toe movement and MED, and also for other signs of Blepharophimosis syndrome. And as the congenital ptosis can come under congenital cranial disinnervation syndrome, we should also check for Quadrants and congenital fibrosis of extraocular muscles. So equal innervation is other important one. When we are manually elevating the ptotic lid, there can be drooping of the normal looking eye. So this gives an idea about what we are dealing with, a bilateral case or not. And also this will help us to counsel the patient about the bilaterality of the disease. And there can be drooping of the normal looking eye when we are doing the correction for the ptosis. And in young people, we should check for any signs of blepharophimosis, that is paper like upper lid skin and fat atrophy. And also we should check for lid laxity and papillary conjunctivitis. It can be seen in floppy eyelid syndrome. So the causes of mechanical ptosis like edema, tumor can be checked, and the type of trauma should be checked. And LPS action, what we are usually doing is the Burki's method. It's very important because we can plan our surgery depending on the LPS action. So after negating the Frontalis action, we'll ask the patient to look down and then ask the patient to look up. So that excursion of the lid gives the LPS action. It can be graded like poor, fair, good, and normal. And in congenital cases, LPS usually will be less, and in acquired cases, it will be near normal. And there is one more type, is Illis method, usually do in infants. We'll invert the patient's upper lid, and how fast the everted lid is coming back to normal position, it gives the idea about the LPS. If the eversion is lid is coming back to normal position very fast, means the LPS action is. And this Tassel show is also very important, which can give an idea about the symmetry of the eyelids. What are the prognosticating factors? So after ptosis surgery, there can be lag of thalmus. So if the patient is having a pre-existing lag of thalmus, poor Bell's phenomenon, and patient is having decreased corneal sensation and dry eye, that gives us an idea that the patient can have, this patient is more prone for exposure keratitis after the surgery. So this should be taken care of. And phenylephrine touch is also important. When we are putting 2.5% phenylephrine into the eye, if there is improvement of ptosis, that predicts the potential eyelid lift possible after the Muller's muscle conjunctival resection. In all cases of ptosis should be checked for pupil and extraocular movements. This triad should be very important. In all cases of ptosis, we should check for pupil and extraocular muscles. So it will give an idea about whether we are dealing with any myasthenia gravis, Turner palsy, or other myopathic causes. In myasthenia gravis, along with this, we should check for Hogan's linkage. That is the upward excursion. When we'll ask the patient to look down for 15 seconds, and we'll ask the patient to look to the normal position. That time the ptotic lid will go a little high and then come back to the normal position. And peak sign shows the decreased orbicularis zone. When we ask the patient to close the eyelids, the patient will keep and see. We should check for fatigability, and fatigability is not specific to myasthenia gravis. It can be seen in aponeurotic and all other causes of ptosis. We can do eye spec test in our clinic. Ectropion and neostigmine is needed. And we can send the patient for other investigations. Oculomotor pulse is very important. It can be either complete or partial. If the patient is having anisocoria of more than 2 millimeters, it should send for immediate neuroimaging to rule out any aneurysm. It should also check for aberrant regeneration signs of oculomotor nerve. And if the patient is having a mild ptosis, and we should check for any other components of Coronal syndrome. If it is present, we have to evaluate for the ptosis. And chronic progressive external ophthalmoplegia patient will have poor LPS action, no diplopia, along with extraocular external ophthalmoplegia. There will be no diurnal variation, which will differentiate from myasthenia gravis. The patient can have a Canthal syndrome association also, so we should check for cardiac conduction. Other causes are oculopharyngeal muscular dystrophy, myotonic dystrophy, ophthalmoplegic migraine, multiple sclerosis, and GV should be in our mind when we are dealing with the ptosis. So, a best corrected visual ophthalmic examination should contain best corrected visual acuity without any amblyopia, especially in cases of congenital ptosis. And systemic and neurologic examination should also be. And also, we should assess the patient. But why the patient comes? Whether he is having any cosmetic, more concerned about cosmesis, or whether he is having any functional defects. And also, we should see the patient is having any unrealistic goals and counsel the patient properly. Photo documentation is important. We should ask for all photos, and also we can ask the patient for nocturnal photos of sleep, check for nocturnal participants. And also, we should have pre and post of photos. And this is the summary. These are the measurements. These are the other associated signs, and we should also do cover test and cover test, blood test, and specific test for the each type of case. These are my references.
Thank you, Soumya. It's a really nice class. So to conclude, examination is the most important part of ptosis evaluation. Careful examination that all points should be really taken care of, and also seeing the old photos. So these two will itself gives close to the etiology of ptosis, and also the grading is very important. LPS action is important, so that will help us to plan the management. And equally important, the ISPAC test, Herring's test, and the phenylephrine test. So this will also give us the important clues to the diagnosis. Maria ma'am, anything to add?
There are some very intelligent examiners. They will ask, when ptosis with hypertropia, how will you measure? Actually, in fact, asked to one of our DNB residents, when there is hypertropia, how will you measure MRD?
We correct the hypertrophy with cover test, and then measure.
That's the most important. The hypertrophic eye has to be fixed. So you can close the other eye and ask the patient to look straight. So the pseudotosis will get revealed at that time. Then any exam questions, Dr. Sujitra?
Ma'am, you are muted. Can you unmute?
Can you unmute? Yeah.
Yes. Yeah, she very explained in detail. Exam point of view, usually simple ptosis are kept for MS exam. So all the examination point, they should know how to do that measurement. And mainly doing this levator action, they should do proper negation of this frontalis muscle that they observe. Otherwise, all points are mentioned.
Thank you.
Thank you, Soumya. Thank you, ma'am. Let me introduce Dr. Sujita.
Sujitra.
Yeah, 1 second. Okay, let me introduce Dr. Sujitra, ma'am. So she's a professor in ophthalmology, currently working in Amrita Institute of Medical Science, Kochi. Thank you so much, ma'am, to be a part of this program. Thank you.
Shall I start? Is my screen visible now?
Not yet.
Not yet.
Wait 1 second. No.
Yeah.
No.
Yeah.
Yes.
So go to full screen. Okay.
No, yeah, yes, ma'am. Now it is full screen. Thank you.
Very good morning to you all. Thank you, Marian, for including me in this session. So straight as the examination part and evaluation part is explained in detail, I'll straight away go to management of ptosis. In congenital ptosis, timing of surgery is very important. If the ptosis is mild and not blocking the pupillary axis, you can wait till 3 to 4 years of age so that you can assess the ptosis better and the facial tissues are better developed and better post-operative care is also possible. But if the ptosis is severe and it is blocking the pupillary axis, we have to intervene early. And in bilateral severe ptosis and or moderate ptosis with bad head posture, that is chin elevation, then again we need to intervene early. And the choice of surgical procedure is determined by whether ptosis is unilateral or bilateral, and the severity of ptosis, that is explained by the previous speaker, and about the amount of levator action, and whether the ptosis is simple or complicated, that is associated with other ocular anomalies. So detailed examination of eye is very important before we plan our procedure. So these are the commonly performed surgery. They are fascicular servet operation, levator resection, and brow suspension ptosis repair. When the ptosis is mild with good or excellent levator action, fascicular servet procedure can be done. And when mild ptosis with levator action less than 10, levator resection can be performed. And moderate ptosis with good or fair levator action, levator resection is performed. And in severe ptosis with fair levator action, again we can decide whether levator resection or brow suspension. Then poor levator, severe ptosis with poor levator action, brow suspension ptosis repair is done. Coming to fascicular servet surgery, it is posterior tarsoconjunctival resection. It is done in mild ptosis with good levator action. So here, the eyelid is averted. We have to give local anesthesia along the lid crease and also can inject subconjunctivally. And eyelid is averted and 2 artery clamps are applied, which includes the superior margin of tarsal plate conjunctiva. Then you can excise that tissue, which includes conjunctiva, part of molars, and tarsal plate. And sutures are passed through this before you excise the tissue. Okay, then these sutures are exteriorized through the skin incision. Absorbable sutures are used so that the knot is exteriorized so that it won't cause any corneal abrasion. And to protect the cornea, we can put bandage contact lens, and post-operatively we have to use lubricants, okay, ocular lubricants. The expected complication or potential complications are undercorrection, overcorrection, lid contour deformity, corneal abrasion, dry eye. So if we do proper preoperative evaluation and measurement, we can reduce all these complications. That's a pre and post-operative picture of a patient who underwent fascicular servet procedure for a mild ptosis with good levator action. So conjunctivo-mullarectomy. Here again it is done for mild ptosis with excellent levator function, The advantage of this procedure is the tarsal plate is not disturbed. Okay, here we are excising only the conjunctiva and Muller's muscle. Here the phenylephrine test helps. So when you apply phenylephrine eye drops, if there is good elevation, then we can opt this procedure. This is again done through the conjunctival approach. And incision is made on the superior margin of tarsal plate. Then conjunctiva and the Muller muscle are dissected out. Usually about 8 to 10 millimeter of tarsal conjunctiva is excised, and it is sutured over the superior margin of tarsal plate. It gives good cosmesis, and it's a good procedure for mild ptosis with good levator action. It's a pre and post-operative picture of a patient who underwent conjunctiva Mullerectomy for mild ptosis. Coming to levator resection, this is commonly performed procedure. So usually done for moderate ptosis with good levator action. We can do either anterior approach or posterior conjunctival approach. And the amount of levator resection, levator to be resected, there are various calculations. If it is 1 mm ptosis, if you resect about 3 millimeter of levator, you get 1 mm correction like that. But it is not that accurate. And the general rule is, if the levator function is good, you aim for optimal lid position. And if the levator action is poor, you do maximal levator excision. The supramaximal levator excision is done for severe to moderate ptosis with poor action of levator, where you excise about 30 mm of levator. Here again, incision is made along the eyelid crease and dissect underneath the orbicularis and locate the levator aponeurosis and dissect. And to locate the levator aponeurosis, it is the levator aponeurosis is present deep to the orbital fat. So when you open the orbital septum, you can see the orbital fat prolapsing out. And when you retract the orbital fat, you can see the levator aponeurosis. And you can excise the required amount of levator. Then you can close. To reattach the levator aponeurosis to the anterior surface of tarsal plate, we use non-absorbable suture, that is Proline 60 Proline. Then to close the orbicularis, absorbable sutures are used, that is 60 Vicryl. And while closing, we can make a lid crease forming suture. Here you have to pass the suture through the levator stem. And skin can be closed either with the interrupted suture or with continuous subcutaneous sutures. This is again pre and post operative picture of a patient who underwent levator resection. Coming to Frontalis sling surgery, it is done for severe ptosis with poor levator function. Okay. Fascial lata, the material used as a sling are fascial lata, silicone rod, and Proline sutures some surgeons use. But nowadays, silicone rod is the common material used as a sling. Here we are using the action of frontalis muscle to lift the eyelid. Here I'll show you. So the incisions are made on the eyelid, 2 incisions on the eyelid, that is about 2 millimeters from the eyelid margin, then 2 incisions on the eyebrow, which is so, and one incision on the forehead, so that you get a pentagon shape. Then you pass the silicon rod through all these incisions. So you can start either from the eyelid incision, or you can go from eyebrow incision. So assess the eyelid elevation. Then you fix the sutures, like a silicon rod. You pass the silicon rod through the sleeve and adjust the height of the eyelid. Then bury it under the deep tissue plane, that is submuscular plane, and close all this wound. So pre and post-operative picture of a patient who underwent Frontalis Sling surgery for severe ptosis with poor levator action. So coming to complicated ptosis, here there is ptosis is associated with other ocular abnormality. Okay. In case with superior rectus involvement or double elevator palsy, you have to correct the hypertropia first, then do the ptosis surgery as a secondary procedure. Then in Blepharophimosis syndrome, again the components of Blepharophimosis are epicanthus inversus, telecanthus, then narrowing of palpebral fissure, both horizontal and vertical, then ptosis, severe ptosis. So epicanthus inversus is corrected by Mastardis double set plasty or VY plasty. Okay, here this picture shows the VY plasty. Okay, you make an incision like this, then dissect the tissue, then suture this. So you are putting an Y-shaped incision. Then after once you suture, the extra fold of skin gets corrected here. Then telecanthus is corrected by transnasal wiring. Okay, here you can see the picture. The sutures are passed through the canthal tendon, and using the SS there, you can tie both canthal tendons. So the telecanthus gets corrected here. Lateral canthoplasty is done to increase the palpebral fissure length. Horizontal shortening is corrected by this. Then bilateral ptosis surgery is done to correct the ptosis. The bilateral frontalis sling surgery. Okay. Now, these procedure can be done as two-stage procedure. That is a correction of epicanthus, telecanthus, and lateral canthoplasty as primary procedure, and ptosis correction as a secondary procedure after 6 months. Or these can be combined and can be done as a single stage procedure. Here the epicanthus inversus is corrected by double Z plasty. Okay. So there are two Z plasties here. The incision is called jumping man incision. You can see that picture as a jumping man, and this part, the medial part, is the corrected position of medial canthus. After dissecting this, you have to expose the bone there and make a hole there, pass the SS there, and suture both medial canthal tendon, pull it so that the medial canthus is shifted towards medially. And after that, have to suture this flap. Okay, then ptosis correction is done. So this is the pre-op picture of a Blepharophimosis child, and this is post-op picture. See the video of correction of Blepharophimosis, the flap being dissected. And medial canthal tendon is identified and disinserted from the periosteum, and opening is made in the nasal wall. Here we are using 40-prolene for transnasal suturing. This SS wire is ideal. Here we can see the correction of telecanthus maxillary. Then this correction of ptosis by Frontalis sling surgery. So this can be done as a secondary procedure or as single stage surgery also can be done. So pre and post-operative pictures of Blepharophimosis syndrome. In Marcus gun ptosis, so there is jaw winking and ptosis. If the jaw winking is minimal, then we can do fascinella servate or levator resection. If the jaw winking is prominent, then we have to do levator excision to negate the action of levator so that the jaw winking is reduced or abolished. Then we can do the brow suspension. Again, here previously for unilateral Marcus gun jaw winking ptosis, bilateral levator excision with bilateral brow suspension surgery was done. But now recently, nowadays, it is done only in the affected eye. The bilateral surgery gives better prognosis. Now, most of the patients or parents, they do not want the normal eye to be disturbed. Okay, so now most of the surgeons or most of the surgeries are unilateral. Here the patient has to learn to use the frontalis to lift the eyelid. Again, in misdirected third nerve ptosis, again levator excision with brow suspension surgery is done. Here you can see the Marcus gun jaw winking. There is opening of eyelid with jaw movement to opposite side. So you have to do levator excision. You have to dissect the levator muscle and excise good amount of levator muscle. So that you are creating an ptosis there. Then you correct the ptosis with eyebrow suspension or frontalis suspension. So in ptosis with third nerve palsy or progressive external ophthalmoplegia, where patient have movement restriction, ocular movement restriction, and there won't be any Bell's phenomenon. So if you do ptosis correction, they will have severe exposure keratopathy. So we can give either touch classes where patient can use it. They have to, when they are moving or reading, they can use it. And when they learn how to close and open the eyelid using this crush glasses, where there is one metallic projection which lift the eyelid. Or we can do conservative sling surgery, that is minimal correction, just optimal correction. You place the eyelid just above the pupillary margin so that patient can move without difficulty. And we have to use ocular lubricants liberally for surgery. They are prone for exposure keratopathy or exposure keratitis. Sometimes we may have to reverse the surgery. Thank you. And here in aponeurotic ptosis, we need not do resection. We have to just reattach the levator aponeurosis to the anterior surface of tarsal plate. that I haven't included here. Otherwise, thank you.
Yeah.
Thank you, Sujit Raman. It was a very nice class and with all the beautiful videos. I think all points are covered, all surgeries are explained. Maria ma'am, you want to add anything?
No, I think it was well covered. It's very useful for the exam. Like nowadays they ask, previously during our time, they never used to ask the steps of LPS resection and all. So nowadays, because of the improvement in the knowledge and accessibility, the steps of ptosis surgery being asked. During our time, like, like when will you do LPS resection? When will you do Frontalis Sling? That's it. Now they started asking the steps of LPS resection, steps of Frontalis Sling, etc. Okay, thank you, Doctor. Yeah.
Complications of ptosis surgery, management
Yes.
of complications of ptosis surgery.
That is one theory question. Management, complications and management. Thank you. It's a well covered ptosis. Yeah.
We should also know how to draw the diagrams of both the Frontalis Sling methods, Fox Pentagon and Crawford's technique. So that is also sometimes asked. Okay.
I think we have covered the ptosis. Yeah.
Can I stop sharing?
Yeah.
Thank you.
Now we will move to the next topic. Again, we are tackling with the lid only. Evaluation and management of ectropion and entropion by Dr. Shebin Salim from Giridhar Eye Institute, Kochi. Over to Dr. Shebin, please.
Yes, thank you, ma'am. I'm sharing my slide. Is it visible?
Yeah, it's visible, but just make it full screen. Yeah, full screen now.
Okay, yeah, thank you. So let us go straight away go to the topic. So first, we should know the anatomy. Without knowing the anatomy, we can't evaluate or decide the management. So what is keeping the eyelids in its position? So the rigidity is given by the tarsal plates, which are kept in position by the medial and the lateral canthal tendon. The medial canthal tendon in turn is attached into the anterior and posterior lacrimal crest, and LCT is attached into the Whitnall's tubercle. The tarsal plates are also supported superiorly by the LPS muscle and the Muller's muscle, which are the retractors, and inferiorly by the inferior retractors, that is the capsulopalpebral fascia and inferior tarsal muscle. And the anterior lamella component, that is the orbicularis muscle, also important part of maintaining the integrity and the integrity of the lids. Coming to the evaluation. So first, see, it is almost same for both ectropion and entropion. Mainly, we have to assess the lid, the laxity, the lid margin. So first, see how much is the extent of the ectropion or entropion and what is the grading. And carefully examine the lid margin. You should know the normal anatomy first. So anterior, it has got the lash line, then the intermarginal strip with the gray line. Posterior to that is the meibomian gland orifice. Posterior to that comes the mucocutaneous junction, and the posterior border is a sharp border. And see if there is any lid margin keratinization is there, trichiasis is there, dystrichiasis is there. And also see the puncta, whether it is opposed to the globe. If normally the puncta will not be seen. If it is seen, that means punctal ectropion is there. And also see how is the aperture, punctal aperture, if there is stenosis is there. And then look for the anterior and the posterior lamella. If there is any scarring, cicatrization, exposure changes, and that will give the etiology, clues to the etiology also. And then the laxity that I will detail later. And also look for any orbicularis ocular weakness and check the patient as a whole, examine the whole face if there is any signs of facial nerve palsy. And also slit lamp examination is equally important. See for any exposure, corneal exposure keratopathies, any scarring is there, whether any lashes are rubbing over the cornea. So first is, so coming to the test of lid laxity, first is the pinch test, in which the lower lid is pinched and is pulled anteriorly, like horizontally, and see how much it is coming off from the globe. If it can be pulled more than 6 mm, that means lid laxity is present. Next is the snapback test, in which downward traction is applied on the lower lid and released, and see how fast it is returning to the original position. In normal people, it will return immediately. In grade 1 laxity, it will take 2 to 3 seconds, 2, 4 to 5 seconds, 3 more than 5 seconds, but it returns after a blink. In grade 4, it continues to hang down even after blinking. Then for medial canthal tendon laxity, lateral traction is applied on the lower lid. Usually the puncta can move up to 1 to 2 millimeters. If it is moving beyond that, that means there is a medial canthal tendon laxity. So if it is mild, if it is going up to the limbus, moderate if it is going up to the pupil, and severe if it is going beyond the temporal pupillary margin. Similarly, for LCT laxity, medial traction is applied. So, and see if it is moving more than 2 millimeters. And also the contour of the shape of the lateral canthus is a sharp. It is acute angle. See if there is rounding is there or not. And also it is positioned within 1 to 2 millimeters from the lateral orbital rim. So if it is gone beyond that medially, that means there is a weakness or disinsertion. Ectropion is outward displacement of the eyelid margin. It can be classified congenital or acute. Acute could be involutional, paralytic, cicatricial, or mechanical. Now, what is the cause for involutional ectropion? It is because of the age-related laxity of the eyelid, and also there could be associated orbicularis muscle weakness. Now coming to the cicatricial ectropion. So cicatricial ectropion is because of the shortening of the anterior lamella, basically skin and the orbicularis, that can happen following trauma, chemical injury, burn, or cicatrizing skin diseases. And how do they usually present? The patient can present with complaints of redness, irritation, watering, and sometimes with the cosmetic problem of the lid turning outwards. And what are the causes of ectropion? So this is usually multifactorial. Could be due to reflex lacrimation because of ocular surface irritation, or it could be due to punctal malposition, and that can itself lead to punctal stenosis, and could be associated lacrimal pump dysfunction because of facial palsy or orbicularis weakness, age-related weakness, that could be there. So grading is, grade 1 is punctal eversion, 2 is eversion of the sharp posterior lid margin, 3 is the palpable conjunctival exposure, 4 is the exposure of the fornix. So there are different options for the management. So it all depends on what is the etiology, what is the underlying mechanism, and how severe is the ectropion. So we'll go through one by one. Now, first is the full thickness pentagonal wedge resection. So this is done when we do this procedure. So this is done when there is horizontal lid laxity without much of a medial or lateral canthal tendon laxity. So first step is making a full thickness vertical incision where the ectropion is pronounced. So once that is done, overlap these two strips and see how much excess horizontal lid is there. So that will that way mark the second vertical incision and form a wedge and do a direct closure. Now, one important thing is that whenever we are doing this lid tightening procedures, also we have to do a careful preoperative examination to see if there is any lid retractor laxity or disinsertion. So if that is there, if we do too much tightening, it can cause complete eversion of the tarsal plate. So this also needs to be corrected. That means the retractors also needs to be reattached. Second one is lateral tarsal strip. So this is done when there is a horizontal lid laxity, mainly the lateral canthal tendon laxity. So the first step is making a lateral canthotomy. Second step is making an inferior cantholysis. That means cutting the lower limb of the lateral canthal tendon that will make the lower lid free to move. Now, mark the new canthal position after see how much needs to be excised, how much it needs to be tightened. So once that position is marked, then the lower lid retractors are released from this much area, and the tarsal strip is fashioned by removing the conjunctiva from posteriorly, the lash follicles from the lid margin, and the anterior lamella, that is skin and orbic, is removed from anteriorly. Next is making a pocket inside the lateral orbital rim to expose the lateral orbital periosteum. So it should be around 2 to 3 millimeters from posteriorly to the rim. And also the horizontal level is important because the normal position of the lateral canthus is 2 millimeters above the medial canthus. So this new attachment should also be around 2 to 3 millimeters above the medial canthal position level. So that is done. Then the canthus is reformed and skin and orbicularis is closed. Now, so we told about how to deal with the horizontal lid laxity when there is a LCT laxity. Now, when there is a medial ectropion without much of horizontal or LCT laxity, in that cases we can do a medial spindle procedure. So first step is passing a probe through the puncta to safeguard the canaliculae. Then a medial conjunctiva, diamond-shaped conjunctiva with some amount of subconjunctival tissue is excised from below the lower border of the tarsus. And this excised tissues, this can also be extended slightly laterally if you feel that the medial ectropion is extending a little bit laterally also. Now this is closed directly or can also be combined with a inverting or rotational suture. So now we have 3 named procedures, which we are not doing routinely, but is important for the exam purpose. One is the Kuhn-Simonowski procedure, the Laxity procedure, and the big procedure. So it is actually very easy to remember. So basically the Simonowski procedure and the Laxity procedures, both are combination procedures. So this contains 2 procedures basically. One is a wedge. And in Kuhn-Simonowski procedure, the wedge is done laterally. And this is combined with a lower lid blepharoplasty. So this is done in patients who has a ectropion with laxity and who require a lower lid blepharoplasty also. And similarly, in the Laxity procedure, the wedge is done medially, lateral to the punctum, and it is combined with a medial spindle procedure. So this is done when there is a horizontal lid laxity with medial ectropion. So basically, these 2 procedures contain wedge. One is done medially, one is done laterally, and is also combined with in Simonowski. There is a blepharoplasty, and in this Laxity procedure, there is a medial spindle procedure also. This is called Laxity because the final wound shape will be a T, lying down T. Okay, the vertical limb and the horizontal limb. So big procedure is of only historical importance. So this is more or less like a wedge, which is done flush to the lateral canthus under a skin flap. Now, if there is a severe medial canthal tendon laxity, it needs to be fixed to the posterior lacrimal crest. There are multiple ways of doing that, not going into the details. Now, coming to the management of cicatricial ectropion. So the 2 main procedures are setplasty and a full thickness skin graft. So when we do setplasty, when there is a linear scar that is pulling or causing ectropion of the lid. So first thing is doing, if the scar is extending up to the lid margin, then we have to fully excise the lid margin scar by like a wedge or a pentagon. Then the lid margin is closed. Then excise the scar in its whole extent and remove all the scar tissues and make these linear incisions on either end of the wound. So this angle, which should be 60 degrees, and the length of the, this horizontal incision should be equal to the length of the wound. But if the wound is too long, then we can do multiple setplasties. Okay, so the flaps are undermined and then are transposed. Now coming to full thickness skin graft. So if the cicatricial component is diffuse, if it is not a linear scar, if it is a diffuse scar, then full thickness skin graft is done. The donor areas from where we can get the graft could be upper lid, preauricular or postauricular area, supraclavicular area, or upper inner arm. Now, the paralytic ectropion needs more complicated management. So depending upon the extent, multiple procedures may needs to be done, a lateral tassel strip or a medial canthal tendon plication, medial canthoplasty. And in severe cases, it needs to be managed with a fasciolata sling, which passes through the whole extent of the lower lid. And sometimes if there is severe mid-facial droop, that also needs to be corrected by lifting up, because the pull of the gravity will cause recurrence of the ectropion. Now coming to the entropion. So this is inward rotation of the eyelid margin. It could be either congenital or acute. Acute could be either involutional, cicatricial, or acute spastic. So patient usually complains of foreign body sensation, redness, and watering because of the constant rubbing of the eyelashes and the lid margin over the ocular surface. Now grading, grade 1 is only the posterior lid border is involved. 2 is interning of the intermarginal strip. 3 is the whole lid margin is interned. Now coming to the involutional entropion. What is the basic mechanism? Before calling it as an involutional entropion, carefully examine the conjunctiva tarsal surface to see if there is any component of shortening or cicatrization is there. So once that is ruled out, then only label it as involutional entropion. Now, what are the mechanisms? One is horizontal lid laxity. Second thing is overriding of the orbicularis oculi muscle, the preseptal part over the pretarsal part, and disinsertion or attenuation of the lower eyelid retractor. So this is important because this is what we are going to correct. So there are different procedures. We'll go one by one. First is a simple everting suture. So this is as a temporary measure only for involutional entropion. And usually this effect will last around 1 to 1.5 years. So here 3 sets of sutures are passed, like double arch, absorbable 40 or 50 vicary sutures are passed around 2 to 3 millimeter from the conjunctival side, 2 to 3 millimeter below the tarsal border, to emerge obliquely, to emerge on the skin side just below the lash line. So that is quick cut everting sutures. Now coming to the second one, that is quick cut procedure. So in quick cut procedure, we are correcting all 3 mechanisms of entropion. That is horizontal lid laxity by horizontal shortening, overriding by making a full thickness horizontal lid incision that will separate the orbicularis, and the disinsertion of retractors are corrected by retractor attachment. So first step is making a vertical incision, full thickness incision at the junction of around lateral third and medial 2/3. So once that is done, this horizontal full thickness incision is made, cut into either side. So we got 2 strips, 2 free strips of lid margin. Now overlap and see how much excess horizontal lid is there. So that is excised. Once that is excised, the lid is closed as normal. Now, so 2 parts are over. Like we shortened the horizontal lid laxity, we separated the orbicularis. The overriding is broke. Now, third step is reattaching the disinserted or the dehiscent retractor. So that is identified just anterior to the conjunctiva. Okay. And it is then reattached into the anterior lamella. It is not attached into the tarsus in the classical quick cut procedure. It is just sutures are passed on the retractors and it is attached into the skin and orbic. So finally, the sutures will come just below the lash line and the skin is closed. So this is quick cut procedure. So we covered 2 procedures, everting suture and quick cut procedure. Now, V's procedure. So if you remember quick cut procedure, it is easy to remember V's. So in V's procedure, that one component of quick cut procedure is not there. That is making the vertical full thickness incision and like shortening the horizontal laxity. So here the horizontal laxity is not taken care of. So a full thickness incision is made. The retractors are reattached into the anterior lamella. That is V's procedure. Now coming to John's procedure, which is the one which we do nowadays usually. This is also similar to V's procedure, only minor difference. So here the incision, we are not making full thickness. The skin is cut, orbicularis is cut, lower border of tarsus is identified, orbital septum is cut, the fat is retracted to identify the underlying retractors, and the retractors are attached into the lower border of tarsus. That's it. That is John's procedure. Now, John's procedure is combined with a wedge or a lateral tarsal strip if there is a horizontal lid laxity is there. So that is that covers the involutional entropion. Now coming to cicatricial. There are different procedures for cicatricial entropion, and a tarsal fracture and a mucous membrane grafting can be done for both upper and lower lid. And upper lid lid margin rotation and lamellar division can also be done. So we'll go one by one. Tarsal fracture is so as the name indicates, we are fracturing the tarsus. So first step is everting the lid, upper or lower lid, whichever lid, overhead emiris retractor. Then make a full thickness horizontal cut on the tarsus, only on the tarsus. So once that is done, the sutures are passed from the proximal cut end of the tarsus, and the distal end is cut end of the tarsus is not included in the sutures. Sutures are passed to the proximal end and through the orbit, passed anterior to the distal tarsal end, that is through the orbic and skin, to emerge just below the lashes. So that is tarsal fracture. Now we see what is a terminal tarsal rotation or lid margin rotation. It is also known as Strabot procedure. So the first step is the same, making a full thickness cut. Now undermine both the proximal and distal tarsus. So this is the undermined proximal and distal tarsus, and the undermining of the proximal tarsus can be done even above, should be done above the border of the superior border of the tarsus also. Now, these two back cuts are made in the distal tarsal fragment so that we can rotate it 180-degree anterior. So once that is done, we have to pass basically two sets of sutures. One is passed from the conjunctival side just above the tarsal border to come on the skin surface at the lid crease. So this is to make the anterior and posterior lamella opposed to each other because we have already split it. Second suture is made at the newly formed lid margin between the two ends of the tarsus. So I hope these two are clear. Now we are going to anterior lamellar repositioning or a lid split. In this procedure, what we are doing is we are basically repositioning the anterior lamella at a higher level so that the interning is avoided. So first step is making a lid crease incision and exposing the anterior surface of the full thickness anterior surface of the tarsus up to the lash root. And then sutures are passed from the upper third of the tarsus and to emerge just above the lash line. So this will recess or lift up the anterior lamella. So this can be done alone or it can be combined with a lid split. In lid split, we are making a full thickness incision on the gray line so that this strip of anterior lamella lies totally free to move upwards. Now they are recessed upwards and sutured in the new anatomical position. So this row area can be either left alone, and in some cases when there is severe keratinization there where we have sacrificed more amount of tarsus, this can be combined with a mucous membrane grafting also. So this is a patient in which only anterior lamellar repositioning is done, lid margin split is not done. So mucous membrane graft can be harvested from oral mucosa or hard palate. Hard palate is used only for lower lid, not for upper lid. So before concluding just about horse procedure, so this is done in case of epiblephron. Epiblephron is where it is not Ectropion. This is where the lid margin is in normal position, but the lashes are turned inward because of a fold of skin and orbit. So basically we are making a spindle or semilunar shaped incision just enough to evert that lashes to cut the skin and orbit, and the skin and sutures are passed through the skin orbit and taken through the lower border of the tarsus to fix it at that level. Thank you. Almost all surgeries are covered, I hope, but there are still more. It is beyond the scope of this class. Anything needs to be detailed?
Yeah. No, I think it has been well covered. I mean, exam point of view, it's a very common question. If you go through the last 6 years question paper, evaluation of management of Entropion and Ectropion. Even though it looks very confusing, once you understand the lid anatomy and pathology, things are very, very very easy. But I would rather used to tell my students, don't mug up oculoplasty. You can mug up other specialties. You enjoy oculoplasty and learn, because lid has two lamella, anterior lamella, posterior lamella. It can have a vertical laxity, it can have a horizontal laxity. So whatever is where is the find out pathology, where exactly is, and correct it. So that is oculoplasty. Shebin, I think it was well covered. Thank you.
Okay, ma'am. Then let us go to the next
topic.
Go to
the next.
Hope my screen is visible, ma'am. Yeah.
No touch.
Not yet. Okay.
Yeah.
Okay. So let us welcome the next speaker, Dr. Sushma. She completed her fellowship in oculoplasty from Giridhara Institute under Dr. Marian, and at present she is working as consultant at Department of Oculoplasty in Narayan Nethralaya, Bangalore. Welcome, ma'am.
Thank you, Dr. Shebin, for the kind introduction. I'll start sharing my screen. Are my slides visible?
Yes, Dr. Sushma.
At the outset, I would like to thank Cochin Ophthalmic Club and Dr. Marian Pauli for the kind invitation. My topic for today is evaluation of an ophthalmic socket. So what is an anophthalmic socket? It is a socket devoid of an eyeball in simple terms. It might be congenital or acquired. Congenital anophthalmia is a very rare condition with prevalence of less than 0.2 to 0.6 per 10,000 live births. Can be idiopathic, sporadic, or hereditary in the form of autosomal dominant, recessive, or X-linked inheritance. It basically happens when the optic vesicle fails to develop, whereas acquired anophthalmia is one where where the socket is devoid of an eyeball as a result of trauma or post-surgery or due to a painful blind eye due to infections, panophthalmitis, or in cases of intraocular malignancies. So before going to the evaluation, let us see how an ideal anophthalmic socket should be. So an ideal anophthalmic socket should be a socket lined with healthy conjunctiva, and the fornices should be deep enough to retain a prosthesis and also permit horizontal and vertical excursion of an artificial eye, that is the prosthetic eye. And the implant should be centrally placed, well covered, buried, of adequate volume, and fabricated from a bio-inert material. And the eyelid should be normal in position and appearance, and it should have an adequate tone to support a prosthesis. Also, the supratarsal eyelid fold, that is the depression of above the upper eyelid and below the brow, and it should be symmetric with the supratarsal fold of the contralateral eyelid. And the eyelashes in the eyelid margin should be normal in position and appearance. And there should be good transmission of motility from the implant to the overlying prosthesis. So with this background of how an ideal anophthalmic socket should look like, we shall move on to the evaluation starting from the history. So we should elicit a detailed history regarding the nature of the insult, the age at which the insult occurred, any preceding surgery that the patient has undergone, like this in this picture where this gentleman had undergone an evisceration surgery in childhood following a traumatic incident. Past history should be elicited in detail, and also radiation history should be elicited as it gives clue towards the bony contracture and thereby the facial asymmetry that results. Also, any history of adnexal and periocular trauma should be elicited. And while eliciting the history, it would be handy to ask the patient for any old photographs prior to the insult, prior to the episode of insult. Thereby, we get a fair idea towards the facial asymmetry and how the eye looked before turning anophthalmic. And then history related to the prosthesis in terms of what type of a prosthesis is used, whether it's a stock eye or a custom-made prosthesis, the duration of prosthesis use, and the fit and the maintenance should also be elicited in detail. Coming to the examination, the anophthalmic socket should be examined with the prosthesis in place and without the prosthesis separately. Facial asymmetry should be looked for, usually downset eyebrows, facial flattening. Facial flattening on the ipsilateral side gives a clue towards the bony contracture of the socket. Also, during the examination, we can look for other signs of orbital wall fracture. And then the next sign that we look for is enophthalmos, as shown in this picture. It is an indicator of the volume deficiency of the socket. It can be examined by inspection in the worm's eye view, wherein the patient lifts his head and then the examiner looks from the downwards for the relative position of both the eyes. And then it is qualitatively measured by Hertel-6 ophthalmometry. Enophthalmos in the presence of a normal-sized implant usually points towards increased orbital volume, thereby giving a clue towards a possibility of orbital wall fracture. Then coming to the eyelids, look for any notches or abnormalities, lid margin and the lash position, lag of ophthalmos as shown in this picture, with and without the prosthesis. And then look for lower lid laxity, stretching and lengthening, which usually gives a clue towards long-term use of an ill-fitting or a heavy prosthesis. And then the upper eyelid is examined for ptosis, levator palpebrae superioris function. And then the superior sulcus is examined for any deepening, and it is compared with the contralateral side in terms of symmetry. So then assessment of the socket, general appearance in the symmetry is assessed. Then the area of the socket is assessed by assessing the depth of the fornices. We all know that the superior fornix is the deepest. However, the inferior fornix is most important as that is the fornix which supports the prosthesis and plays a very vital role in the retainment and the proper fit of the prosthesis. So shallow fornix can be seen in cases of post-enucleation socket syndrome or a bulky conjunctiva post socket reconstructive surgeries or symblepharon formation. And then the volume of the socket is assessed by noting the relative depth of the socket compared to the fellow eye. Then upper lid is examined for ptosis and the superior sulcus deformity. If there is superior sulcus deformity or ptosis, it usually indicates volume loss. Then coming to the assessment of the socket, that is the surface of the socket, we look whether the socket is dry or wet by noting the presence of discharge. Ideally, a socket shouldn't have any active discharge. A sticky mucoid discharge usually points towards inflammation, whereas a yellow purulent discharge points towards infection. And a dry fibrotic conjunctiva is usually indicative of poorly vascularized socket as seen post-chemical injuries or post-radiation. And then we assess for the movements with and without the prosthesis separately, and then compare with the fellow eye. And then inflammatory signs are looked for. Inflammatory signs are usually mucus, chain papillary conjunctivitis, and granuloma as seen in this picture. And then we look for cicatricial bands and the tone of the orbicularis muscle. Then coming to the palpation of the socket, socket is palpated for the presence or an absence of implant in cases with a history of a preceding surgery, that is enucleation or evisceration. And then we assess the position of the implant, whether it is centered, decentered, or migrated. And then the prosthesis is examined in terms of fit, whether it is properly fit or it is rotated or it is sagging down. And then the size of the prosthesis, whether it's a very large and a bulky, heavy prosthesis or it is a small prosthesis. Usually small prosthesis, the patient complains of rotation of the prosthesis. And then we compare its appearance with respect to the fellow eye. And then the movement of the prosthesis is assessed. And then examining of the prosthesis per se, we remove the prosthesis and then evaluate for its type, whether it's a custom made or a stock eye, the size, the color, the smoothness, the edges, whether there's any chipping of edges, are the edges sharp, because that can lead to inflammation and constant irritation of the socket and the surface deposits. This is a picture of a custom made prosthesis wherein the all the edges are smooth, the undersurface is very smooth, there are no surface deposits, whereas this is a prosthesis wherein the edges are kind of chipped and then the undersurface has some porosity and then some surface deposits. And then the position of the implant. So on photographs or when examining a patient per se, you can assess if the implant is well-centered or decentered by drawing an imaginary line passing through the medial and the lateral canthi, and then drop a perpendicular passing through the highest point of the upper lid and the lower lids. And then with these two, with the center of the intersection of these two lines, draw an imaginary circle, and that should be the the ideal position of a well-centered implant. So based on that, you assess whether the implant is well-centered or it is decentered or it is completely migrated. Radiological evaluation is not routinely done in cases of evaluation of an ophthalmic socket. If done, usually a computerized tomography is preferred. And then the specific indications where you go in for a radiological radiological evaluation is in cases of trauma where you would like to rule out other causes, other orbital abnormalities like orbital wall fractures. or in cases of recurrent implant migrations to ascertain the exact position of the implant. So with this background of how to evaluate a socket, we then move on to grade the socket and look into this topic of contracted socket, wherein there is shrinkage or shortening of the orbital tissues, which causes a decrease in the depth of the fornices and the orbital volume, ultimately leading to the inability to retain a prosthesis. So it is due to the conjunctival and the subconjunctival scar formation involving the fibroblast. What are the factors that contribute to the development of contracted socket? History of trauma, chemical injuries, previous surgeries with scar the conjunctiva, poor surgical technique, lack of placement of an implant, multiple socket surgeries, post-surgical radiotherapy, removal of prosthesis or conformer for long durations, chronic inflamed socket caused by a rough or ill-fitting prosthesis. So the most widely accepted and popular grading system of contracted socket is by Gopal Krishna's classification, wherein the socket is graded from grade 0 to grade 5. Grade 0 is an ideal socket where it is lined by healthy conjunctiva and has deep and well-formed fornices. In grade 1, there's only one fornix that is shortened, that is the lower fornix is shortened, and thereby there is shelving of the lower fornix. Grade 2 is where there is loss of upper and lower fornices. Grade 3 is where there is loss of upper, lower, medial, and lateral fornices. Grade 4 is when there is loss of all the fornices. In addition, there is a reduction of the palpebral aperture in horizontal as well as vertical dimensions. And grade 5 is a recurrence of contraction of the socket even after repeated trials of reconstruction. Let's revise all these grades with the help of pictures. This is a grade 0 socket, which is an ideal socket wherein all the fornices are well formed and is lined by healthy conjunctiva. This is a grade 1 grade 1 contracted socket where there is shelving of the lower fornix. Grade 2 where there is loss of upper and the lower fornix. Grade 3 when there is loss of all the 4 fornices. Grade 4, loss of all the fornices. In addition, there is reduction in the horizontal and the vertical dimensions of the socket. Grade 5, it is a malignant contracted socket wherein even repeated attempts of socket reconstruction have failed. Then there's another grading system of contracted socket wherein it is basically Gopal Krishna's classification, which is consolidated into mild, moderate, and severe and malignant contracted socket. It is Byron Smith's classification, wherein the mild category includes grade 1 and grade 2, where only one fornix is involved, and there is shortening of the posterior lamella of the lids. Moderate, which includes grade 3, where both superior and inferior fornices are involved. Severe, which comprises of cases in which all the fornices are involved with phimosis of the palpebral aperture. Malignant contracted socket, it is the most severe variety and it is associated with bony contraction. Whereas in one end of the spectrum, we have a contracted socket where there is shrinkage and shortening of the tissues. The other one is a post-enucleation socket syndrome, usually abbreviated as PES. This is a sequelae of an enucleation wherein there is orbital volume deficiency and changes in the orbital soft tissue architecture, leading to the clinical picture of post-enucleation socket syndrome. Here, there is no shortage or shrinkage in comparison to the contracted socket. So these are the changes post-enucleation where there is loss of orbital volume, leading to the superior sulcus deformity and upper lid ptosis, and which in long run leads to lower lid laxity. Which ultimately leads to the misfit of the prosthesis and unsatisfactory cosmetic outcome. In this picture, you can see there is loss of orbital volume, thereby there is a superior sulcus deformity, and thereby the upper lid droops and the prosthesis moves forwards, and then there is lower lid laxity. So this is the picture wherein you see a deep superior sulcus, the upper lid ptosis, lower lid laxity. What exactly happens in post-enucleation socket syndrome? The orbital tissues that remain after the enucleation, they settle down, thereby leading to the loss of support to the upper eyelid. Thereby, the upper eyelid drops down over the prosthesis, leading to ptosis. When this pseudoptosis is coupled with the hollowness over the upper lid, it leads to the superior sulcus deformity, whereas This is the superior sulcus deformity characterized by the deep upper lid sulcus. So, and then the loss of orbital volume ultimately leads to the prosthesis tilting backwards and gaze upwards, as seen in this clinical picture also. And this leads to a forward pressure on the lower eyelid, thereby leading to the shallowing of the lower fornix and the lower lid laxity, as seen in this schematic representation and also in this clinical picture. So in conclusion, the evaluation of anophthalmic socket includes simple clinical test. However, a meticulous examination is very much necessary so that you can better plan your socket reconstruction procedures and thereby predict your post-operative outcomes more accurately and thereby lead to better patient counseling and make the patient have realistic expectations. So these are my acknowledgements. Thank you all for your patient listening. Thank you.
Thank you, ma'am. Everything, all points are covered in detail. Actually, socket cases are kept more and more in exams nowadays for practicals. And also in theory, also oculoplasty questions are more and more asked, socket reconstruction and evaluation. I think all points are covered. Mariam, ma'am, you have anything to?
No, I think she has covered everything.
Thank you, ma'am. Thank you, Dr. Schecker.
Okay, so we'll go to the next speaker.
Sorry. No, this is Dr. Akshay.
Hello, hi Marian.
Yeah, hi, good morning.
Can you hear me?
Yeah.
Oh, very
Well
good.
audible. Just wait, give me 1 minute, Dr. Akshay. We will introduce you once.
Okay, next speaker is Dr. Akshayji Nair. He's the consultant oculoplasty surgeon at Aditya Jodh Eye Hospital. He finished his fellowship in oculoplasty, orbit and ocular oncology from LV Prasad Eye Institute, Hyderabad. He has many publications, many awards. Okay, welcome, Dr. Akshay.
Thank you. I also did my residency from Shankar Netralaya, where I met Marian, and we were there together for 2 years. So
yeah,
that's how I know her.
Thank you. We are happy to have you as a faculty in COC, Cochin Ophthalmic Club.
Thank you so much. I will just share my screen.
Yeah.
Okay, how do I share my... Okay, I'll share it from here only. Like, all right. Right. So you can see my screen?
Yeah. Slides are visible, audible. Yeah.
All right. So I'm talking about enucleation, evisceration, exentration. And given that this topic is the program of the meeting today is focused for residents and fellows and trainees, I'll be talking specifically regarding, how to examine surgical videos and questions that your examiner may ask you during your examination. So enucleation and evisceration are destructive surgeries. They, in many ways, it's a paradox because we are giving comfort by causing, almost like an amputation of an organ. But the main part is that you are giving the patient comfort from a painful condition. And while you do that, you also replace the volume and cosmetically and functionally improve by rehabilitating the orbit. Now, this is a table that you should know very well. The two things, the first line and the last line, intraocular malignancy is an absolute contraindication for evisceration, and panophthalmitis is an absolute contraindication for enucleation. The reason being, panophthalmitis means that the inflammation or infection is across all three courts of the eye, which means the choroid, the sclera, and everything surrounding even up to the optic nerve. It is involved in the infection. So if you do an enucleation, there is a chance that the infection may spread along the optic nerve sheath intracranially. Although in clinical practice, I have not seen that happen. But for the examination, you should always remember these two things. Everything else of phthisis, painful blind eye, endophthalmitis, all of these, you can interswitch whether it's an enucleation or an evisceration. So in an enucleation, what is done? The entire globe is removed while preserving other orbital tissues like the extraocular muscles. This is a child who underwent an enucleation, and you can see post-op with a prosthesis, you barely can tell the difference. So what are the clear indications? Intraocular malignancies, a large choroidal melanoma, a group D or a group E retinoblastoma, a medulloepithelioma, or a procedure of choice when the intraocular pathology is unknown. Sometimes you can't differentiate clinically between a Coats disease and a retinoblastoma. Sometimes you see a mass, but there is dense vitreous hemorrhage, so you don't know what is the nature of the mass. Or there is a trauma and there is old trauma, following which there is a risk of sympathetic ophthalmia to the other eye. And finally, of course, cadaveric eyes for donation, it's a relative indication. So these are the absolute indications for an enucleation, whereas in an evisceration, it is a removal of the intraocular contents such as the corneal button, the uvea, the retina, the vitreous, but you leave behind the sclera, the scleral shell, and the extraocular muscles intact in the eye itself. Indications for this are panophthalmitis, expulsive choroidal hemorrhage, staphylomas, disfigured blind eyes, endophthalmitis, etc. When do you choose? Like I said, apart from those absolute indications, you are able to, depending on your surgeon comfort, you can decide whether you want to do an enucleation or an evisceration. But in clinical practice, for a phthysical eye or a disfigured blind eye patient who wants cosmetic correction, I find evisceration gives a better advantage, more advantage, because there is less disturbance of the orbital tissue and the physiological dynamics of the muscles are intact. Also, there are studies that have shown that there is a slightly better cosmetic outcome, better motility, and lesser complications like implant extrusion in evisceration. The only pitfall of an evisceration is if you do not, there's a rare chance of sympathetic ophthalmia. And in some cases, even though it may be a physical eye and you may do an ultrasound, there could be a rare chance that there is an intraocular tumor in these cases. Of course, this is very rare and it's been discussed in this paper. So this is just an academic thing. Preoperatively, how do you talk to the patient? You need to counsel them thoroughly, because they, at the end of the day, even if it is a physical non-functioning eye, you are losing an eye. It is an organ and you are going to remove that. So you need to, the patient needs to be aware of it. They need to get a thorough consent, and your consent for an enucleation or evisceration should be countersigned by another ophthalmologist. Get a B scan done for documentation and photography done. It's always a good idea to show patients who are going to undergo surgery a before and after prosthesis photos of other patients, so they understand what they are expecting, and also they have a realistic idea about motility and other issues. So I'll quickly run through an evisceration video. Here, the first step is to do a thorough peritomy. Nicely make sure that you cut the conjunctiva at the limbus. Once this is done, the next step is to do a to splay the conjunctiva in 4 quadrants between the recti muscles. Then to make a stab entry such that you are able to remove the corneal button. Once this is done, then you have the intraocular contents which needs to be removed. The corneal button is removed completely, and here you introduce a scoop in the suprachoroidal space between the sclera and the choroid. You can also do what is called hydrodissection here. In the same plane, you inject saline, and the fluid creates a cleavage plane between the choroid and the sclera, and the entire intraocular contents can be removed in toto in one go like this. So you don't need to go in multiple times and keep removing. Then you remove all the sclera, the retina and the choroid. Used alcohol to denature any remnants of the choroidal tissue, because you do not want it to be the source of an immunogenic allergic inflammatory reaction that could cause sympathetic ophthalmia in the other eye. After you've used alcohol, give a thorough saline wash. Once this is done, you ask an assistant to hold the scleral shell at the point of one of the recti muscles. So here you can see I am holding the inferior rectus and the Assistant is holding the medial rectus, the sclera on the medial rectal side, and then the incisions are made in between each of these the points of holding, such that you have 4 petals formed. Each of these petals is attached to one recti muscle, and the posterior cuts reach right up to the optic nerve, such that posteriorly these scleral flaps are detached. You can see each of these 4 petals only attached to a recti muscle. Posteriorly at the optic nerve end, they are completely free. So therefore, now when you put the implant goes posterior to the scleral shell. Therefore, it is truly an orbital implant. Following this, you close and oppose the flaps of the sclera, diametrically opposite flaps with 6O vicryl, the horizontal flaps first and then the vertical flaps, or either way, such that there is complete coverage and there is no exposure of the implant. The next step is to close the tenons. And once the tenons is closed, then you close the conjunctiva in a single continuous first string suture. Once this is done, you put in a conformer and then take a tarsorrhaphy. All right. So once we finish in evisceration, of course, you can have different varieties. In infective cases, you may not want to put an implant. You can just do an evisceration. You can do evisceration with sclerotomies if it's a staphylomatous eye where the sclera is big. And like we mentioned, in this case, evisceration with optic nerve disinsertion. Evisceration, in my experience, allows you to place a larger implant and adequate volume replacement is there, and it gives better motility. Now in enucleation, what is done is the globe is removed and the muscles are detached and then reattached to the conjunctiva in the fornix where they were originally attached. In enucleation, you also can add an integrated or a porous implant, either wrapped or unwrapped. Now I'll go through the video also. In enucleation, we always do, I prefer to do a myoconjunctival technique, which I will show. The precautions for an intraocular tumor, such as retinoblastoma, is that you want to minimize the possibility of a globe perforation and make sure that a long optic nerve stump is obtained. Because in a retinoblastoma, the tumor can spread along the optic nerve, which is why the prognosis changes if the optic nerve is involved, and therefore you have to make sure that the optic nerve cut end is free of any tumor. Now, in this case, the first thing I always do is a lateral canthotomy, cantholysis. This allows for greater space and access to the optic nerve laterally. As always, the first step is a peritomy. Now, again, after peritomy is done, you have to separate the tenons and the sclera and the globe. So that dissection is important. Then I hook the muscles. The first muscle that is hooked, and after close to the base of the insertion, I pass a 6-0 silk. This is a traction suture. Just 6 millimeters behind, I take a tag suture with a vicryl suture. This is a double-armed suture. The vicryl is passed, and in between these two sutures, the tag suture and the traction suture, the muscle is cut. Now, this is sequentially done for all 4 recti. And once all the 4 recti are disinserted from the globe, remember, one end is still attached to the vicryl. Now, the next step is to then cut the obliques. This is the inferior oblique being disinserted, and you can directly cut without having to tag these sutures. Then laterally you enter, and one swift move, cut the optic nerve. Apply hemostasis for 2 to 3 minutes, and then observe and notice and make sure you are in the right space. Now, this is posterior to the posterior tenons, which is held by the 4 forceps. You can see orbital fat, and in that space, the implant goes in. So obviously, the first layer to be closed is the posterior tenons. I use an absorbable suture like 6O vicryl in this. The posterior tenons is closed in layers. For beginners, it is difficult to differentiate posterior tenons, anterior tenons, and conjunctiva. But with experience, it will come. All these videos are available on my website or on the YouTube channel. So take your time and observe later. The next step is important. Now, those vicryl sutures that were still attached to the recti muscles are now passed back through the fornix and out through the conjunctiva, each of them in the quadrant where the muscle was originally located. What happens with this is that the fornix is now reattached to the extraocular muscles surrounding the implant. And therefore, now when the muscles move, the implant will move along with it. So This is the main issue, the crux of why it is called a myoconjunctival technique, because the myo or the muscles are reattached to the conjunctiva through the fornix. Once this is done, the anterior tenons is then closed, and then the conjunctiva is closed in layers. I'll quickly go through this video. And as always, a conformer is put in place, and then a tarsorrhaphy is put for about 1 week after surgery when the tarsorrhaphy is opened up. Now we come to the third surgery, orbital exentration. Now in an exentration, not only the globe, the sclera, the optic nerve, everything, all the contents of the orbit are removed. Now there are different types. There can be a subtotal. So a lid sparing is a type of subtotal exentration, because technically an exentration means removing even the skin from the orbit. So eyelid sparing, the most common that we do, is a subtotal exentration. A total exentration is where even the skin, the periorbita, everything is removed, leaving behind only the bare bone. A radical or an extended exentration is when the surrounding structures are involved, such as the frontal or the ethmoidal or the maxillary sinus, either a tumor or a fungal infection. And not only the orbit, but even the surrounding tissues, such as the sinuses and the bone, has to be removed, which is a radical or an extended exentration. Indications: malignant primary orbital tumors, such as tumors that come into the orbit primarily, orbital melanomas, malignant eyelid or ocular adnexal tumors that invade the orbit, like a sebaceous gland carcinoma or squamous cell carcinoma from the conjunctiva, which is invading the orbit. Secondary orbital tumors from the paranasal sinuses or the cranium that have gone into the orbit. Intraocular tumors that have gone through the globe into the orbit. Life-threatening invasive orbital infections. Unfortunately, this for us, as most oculoplastic surgeons, has become the most common indication for orbital exentration. What we have the mucormycosis first, second, and now the third waves as well. In extremely rare cases, severe trauma or orbital contracture, which doesn't allow you to put an orbital implant or a prosthesis, in which case you'd rather exentrate and put an exentration prosthesis. So in an orbital exentration, you can either have a skin covering the socket or the eyelids itself. You may also put a graft to add the volume. Now, this graft could be from the anterolateral thigh, or it could be from the temporalis muscle itself through a bone window that you transfer into the orbit. Complications are hemorrhage, because you are directly cutting second-order vessels, which are branches of the carotid. You can have a CSF leak when you reach the apex. You could have a fistula between the sinus and the skin outside, or of course, infection. So I will quickly run through a video of this also. This is an eyelid sparing exentration, 4 millimeters from the lid margin. I mark all around, and then this is the incision line that we'll be taking. The next thing is to take 3 tarsorrhaphy sutures to suture the lid together. Now, these will give us the traction that we need. Then along the markings, I make a skin incision. Once the skin incision is done all around, the dissection has to be done in the suborbicularis plane above the septum. We make sure that the orbital septum is not opened up, because then the fat comes in, which makes it difficult. So dissection is done superiorly after retracting the skin upwards, such that you reach the orbital rim on all sides. Once you reach the orbital rim, you need to expose the periosteum. Once the periosteum is seen, you have to incise the periosteum and elevate it. Now, this is done 360 degrees on all sides. Now here we are seeing the periosteum and incising it, and now elevating it on all sides. We make an incision on the periosteum 4 millimeters from the orbital rim. Lateral, the Whitnall's ligament, which is on the lateral tubercle. Inferiorly, you'll have the zygomatico-temporal, zygomatico-facial, the infraorbital neurovascular bundles. Most important, lacrimal sac. Superomedially, these two structures. Now, if I pause it here, you can see superomedially, there is the supratrochlear, and supraorbital is seen laterally. These two, again, neurovascular, nerve and muscles together have to be cut. Finally, check that the periosteum is elevated 360 degrees. In one swift, bold cut, again, go up to the apex, or depending on the depth of clearance that you need, and make an incision to exentrate the orbital contents. Again, hemostasis is needed. This was done for a squamous cell carcinoma that was invading the anterior orbit. Therefore, we don't need apical clearance, so some amount of fat is left behind. Surgicel or absorbable hemostatic material is left behind. Orbicularis closure is important, because this orbicularis is what is going to supply blood to the superficial skin on top. And then you remove that. You can, if you leave it bare, you can allow it to granulate. You can use the temporoparietal fascia, or you can use microvascular free flaps also. How do you rehabilitate them? You can have glued on, you can have spectacle mounted, or you can have magnetic prosthesis. This is a lady who underwent exentration for mucormycosis. This is a prosthesis put in place, and with the spectacles, you really can't differentiate that she doesn't have an orbital content there at all. Finally, the last component of our talk today is orbital implants. So what is an ideal orbital implant? One that gives adequate volume replacement, that gives good motility, which is transmitted to the prosthesis. It supports the prosthesis with low rates of complication, which is economical and easy to implant. Now, I say these because porous implants like MedPore are not economical and they need an injector. So they are also not technically easy for everybody to do. They have to be biocompatible, which means that they do not incite inflammatory reaction, and they are non-degradable, which means over time, they do not get degraded by the body itself. Now, these are the variety of implants that are available in the market. So that is why we are in India, all of us always think that implant means a ball implant. But actually, if you see, there are different sizes, shapes, and mechanisms, and which I will explain now. So an implant, classification on implant is a very important question in DNB and MS exams. So implants can be classified either as synthetic or autologous. In synthetic, they can be porous or non-porous. Another way of classification of implants is integrated and non-integrated. And now I will explain to you. If you look in textbooks, there are different ways integration is discussed. So integration can be when it talks about attachment of the extraocular muscles to the implant. Integration can mean physical contact between the implant and the prosthesis, or integration can mean whether the implant is integrated into the orbit through vascular ingrowth, like in porous implants. So these are different ways integration is described. So non-integrated implants are implants that don't integrate with the prosthesis or with the orbital contents, which are the most common ones we use in India. Silicon and polymethyl PMMA, which are no direct or indirect integration of the implant with the orbital structures or with the prosthesis. There are semi-integrated implants where there is indirect or mechanical integration between the implant and the orbital structures, but not with the prosthesis, like Allen's implant. And there are integrated implant where there is an indirect or mechanical integration of the synthetic implant with the orbital structure and with the prosthesis, which means that pegging is done. Now, what is pegging? I'll come to it a little bit later. There are bio-integrated implants where there is direct biological integration through the porous holes in the implant. The vessels grow in and integrate into them. And of course, biogenic implants like dermis, fat graft, or cancellous bone. Porous implants, the most common are hydroxyapatite, porous polyethylene, aluminum oxide. Hydroxyapatite looks like this. These are the pores through which the blood vessels grow in and integrate into the orbit. If you look at a zoomed up size, you can see the size has to be 200 microns or larger for the blood vessels to go in. If it is smaller than 200 microns, it will not integrate. This is slightly advanced for you all. So yeah, PMMA, this is what we use. Why do we use it? It is transparent thermoplastic. It is non-porous. It is biocompatible, very easy, very economical, and it is directly placed in the intraconal space after the enucleation, like we showed you there, or even after evisceration. It goes, if you've done sclerotomies on disinserting the optic nerve, it goes right into the orbit in the intraconal space. Migration and exposure are uncommon. Are relatively common, sorry. When I say relatively common, compared to other implants, it is relatively common. Now, this is what is pegging. Pegging is no longer done, but it earlier used to be done where the prosthesis used to be integrated through a screw onto the implant. So you can imagine the motility must have been very good. However, complication rates were very high. What are the complications? We are talking about complications that could arise from the technique, the implant material, putting a too small or a too large, or if the orbit has received radiation earlier. All of these can lead to complications. The main complications are implant exposure, implant extrusion, and implant migration. Exposure, when a large amount of the tissue over the implant gives way and you can see the implant directly. Extrusion is when exposure increases in size and the implant is just expelled out and you have an extruded implant. Migration is when instead of a centered implant, the implant moves to any one quadrant, giving for poor prosthetic fitting, and that is migration. How do you treat implant exposure? If it is less than 3 square millimeters, 3 by 3 millimeters of an implant exposure, you can conservatively manage with asking the patient to not wear a prosthesis and giving topical antibiotic and steroid. If it is more than 3 mm, you have to cover it. In this case, you can use mucosa, dermis graft, or temporalis fascia, or even amniotic membrane. There are other techniques where you use autologous serum to help in early recovery from an implant exposure. Thank you. I think I've spoken enough.
Yes.
Did I go over time, Mariam? I don't realize sometimes when I start speaking.
No. Actually, it was really wonderful. I think it is post-COVID, in spite of post-COVID bronchitis. So done a great, wonderful job.
Thank you. Last week only I had COVID. But,
yeah. You have covered almost everything, like, the whole exam things, orbital implants, service, endo, exentration, indications, and steps. Thank you so much.
No problem. Is there any questions? We can answer them.
Yeah. YouTube, nothing, I think. No.
All right. Okay. Thank you so much, Marian.
Yeah.
Thank you, Dr. Shebin.
Thank you, sir.
Dr. Sonam, hello. Good to see you.
Hi, Akshay. Good to see you too.
Feroz is
fantastic talk, Akshay. Thank you. And your prostheses were like really nice.
Oh, thank you.
Hi, Akshay. Great talk.
Hi, Feroz.
Hi. Nice to see everyone.
Feroz.
Good morning.
Hey, Feroz.
Hi, Sonam. You're all good, Akshay?
All good. Now, post-COVID recovered.
Oh, yeah. Everyone, I think we couldn't escape it.
I think it was all of our New Year gifts.
Yeah. I wish it got some weight loss also, but it didn't. sorry, Marian, we are hijacking your meeting.
It's okay, no problem. It's okay. Yeah.
Bye. Bye.
Yeah.
Okay.
Thank you. So we'll move to the next talk. Shebin, please. Yeah.
Yes. Okay, so our next talk is by Dr. Nisar Sonam Poonam. She's my dear mentor. She completed her basic medical education from SDM College of Medical Science and Hospital, Karnataka, and her master's in ophthalmology from Mamta Medical College, Telangana. And the fellowship was done from Shankara Nethralaya, Chennai. And at present, she is working as associate consultant at Shankara Nethralaya. Good morning, ma'am.
Thank you so much, Shebin, for that kind introduction, and thank you, Dr. Marian, for having me here. Thank you, Dr. Shebin, as well. Is my slide visible?
Yes, yeah. Just make it full screen, please. Yeah.
Yes, right. So I think orbital imaging is a very vast topic, and I hope I can do justice in the stipulated time. So, well, we all know that about 125 years ago, it was Willem Röntgen who actually introduced the X-ray, but it was used in ophthalmology almost 20 years later. There are two main imaging modalities that we very often use. That is the computed tomography, that is the CT scan, or the magnetic resonance imaging, that is the MRI. So CT scan can either be single or it can be 3D, like spiral helical. And MRI depends upon the Tesla, that is how fine your images you can get. Now, CT scan is very excellent for the bony lesions. Of course, very well used and rampantly used post-trauma in order to see for fractures and any foreign bodies. And also it can be used where MRI is contraindicated, such as when the patient is on pacemakers or patient not mobile, cannot lie down for a longer time. MRI actually has a very superior this thing for soft tissues, of course, tumors and inflammation in case of thyroid eye diseases, and wherein you suspect a wooden foreign body or a plastic foreign body, you can advise an MRI. So what are the prerequisites? Interpretation. Of course, it is very important for us to know the basics and anatomy. Once we know these two, I think everything else falls in place. So just one word, when we are advising for CT scans, most of the CT scans of the orbit that are done outside have actually 5 mm cuts. But if you actually want to look at the orbital apex, the optic canal, you must ask very clearly for 1 to 2 millimeter thick cuts, axial, coronal, and sagittal sections in both soft tissue as well as bony windows. On CT scan, we basically use the Houndfield units in order to assess what exactly is there. And be it CT scan or be it MRI, it is the muscle which is iso-dense or iso-intense. And based on the muscle, the other densities or intensities are hypo or hyper. So this is just a picture to show that this is the axial section. So basically, we know it's basically because of the sutures that you actually term this as axial, coronal, or sagittal. Being a PG, I also used to quite often get confused. So how I used to remember the axial section is, you can see the lateral wall of the orbit, and it looks like an X eventually at the optic chiasm, right? It just merges together. So you can remember that as an axial section. The sagittal section, because the floor of the orbit is a little S-shaped, so you can remember that as a sagittal section. And then there's only one section that is left, that is the coronal section. So that's how I used to remember it to make things easier. The advantage of CT scan is you can just replicate it by doing a 3D reconstruction, like how we used to actually study the bone, the skull in our anatomy days in the MBBS. Now, one thing on CT or MRI also that you can see very clearly is if you put a line, the interzygomatic line, if you draw, you can also assess the amount of proptosis if you cannot assess it clinically, and you often miss it sometimes then, unless there is a shallow orbit. And normally the globe, 1/3 of the globe is within the orbit, whereas 2/3 of the globe is outside. If this ratio is altered and most of the globe is outside that interzygomatic line, as you can see here in the picture, then you term this as proptosis on imaging. Now, what is this? This is an MRI, and this is how it looks. You have two sequences, that is T1 weighted images and T2 weighted images. Just to make it simple, you remember that vitreous and CSF is hypo, or it looks a little blackish, hypo intense on T1, and vitreous and CSF becomes hyper or looks more whitish on T2 weighted imaging. Besides that, if you do a surface coil MRI, you can actually replicate the entire cut section of an eyeball, like how you actually see in pathology. Same thing you can actually replicate as you can see here in the images. But it will have to be specific, and you have to ask your radiologist to do a surface coil technique in order to get this kind of a resolution. You can also see very beautifully that with the surface coil, you can actually see the superior oblique tendon, you can see the trochlear complex, you can even see the inferior oblique muscle, the orbital septum, which actually can tell you between and differentiate between the preseptal and postseptal cellulitis, and the medial canthal tendon as well. Of course, you can also see the nasolacrimal duct and any other sino-orbital lesions, anything which is going into the NLD, which you might probably miss clinically, not have forgotten to evaluate the nose at that point of time. This imaging also comes handy. Also, you can see the optic nerve from its intraocular course to its intracanalicular course very beautifully on an MRI. So MRI is the imaging of choice generally for soft tissue lesions. Now, what we need to know, we all learn in anatomy about the orbital spaces. So when you're actually seeing a CT scan or an MRI scan, it is important first to know what imaging you're seeing, then whether it is plane or is there any contrast. Then you must tell what section it is, axial, coronal, or sagittal. And then you can start comparing the orbits and look at the spaces as well. For all you know, there might be a lesion there that you might miss out. So you can start from outside to inside or inside to outside. As you can see here, you can see the preseptal, then you can see the extracornal area, you can see the subperiosteal and the intracornal spaces. Let's not go into details of that. So let's begin with the first case that I have here. Here is a young lady who presented to us with a history of RTA. And as you can see here, she's got enophthalmos and hypoglobus in the right eye. We ordered a CT scan for her. This is a coronal section of the CT, and down is the axial section. You can see that there is a blowout fracture of the medial wall. But what is more important also is this inferior medial strut that we say that is responsible for holding the globe in its place is also infractured. Thus, she's also having hypoglobus. You can see that the muscle is completely intact. There is no entrapment of the muscle, extraocular muscle. And this was a patient picture after orbital fracture repair. You can see the implant is well in place. Now, here is another girl who came to us, 15-year-old girl who presented to us with a history of mild trauma, and she complained of nausea, vomiting, as well as giddiness. Now, we might often think post-trauma, it could be some neurological cause, but we must not be fooled by the history and definitely look at the extraocular motility. You can see that the elevation is restricted and the eye is completely white, okay? And when we did the CT scan, you can see what is this here. You can see here that there is a subtle discontinuity in the first picture in the coronal cut at the floor, and you can see something is prolapsing out. That is nothing but the orbital fat along with some fibers of the inferior rectus muscle, which is confirmed on the sagittal section. You can see that there is some tethering of the muscle there, and same is confirmed on the axial section. What is this sign called? There's a specific name for this sign, and it resembles and mimics a teardrop, and thus it's called as a teardrop sign, which is suggestive of a white eye blowout fracture. You can see a post-fracture repair, that sign has completely vanished because we've reposited the fat back and we have released the muscle from there. Now, this is a patient, this is a young child, a 3-year-old child presented to us with a very trivial trauma, and then followed by that, the mother says that he has inferior globe dystrophy. I mean, you can see that there is eyeball has gone down. So the child basically has inferior globe dystropia, and we ordered a CT scan for this child. So what do you see here? You see that there is a well-circumscribed lesion in the superior orbit, which is pushing the globe down. Based on the history and the density, turned out that the patient had a small subperiosteal hematoma, which was drained, and this is immediate post-operative picture of the patient. So history is extremely important while you order imaging also, because history and imaging correlates, and your clinical findings, of course. Here is another patient who came to us with complaints of watering. But if you see very closely, you can see that her globe is actually pushed upwards and outside. And if you see very closely, the lesion is actually extending beyond the medial canthal tendon. This raised a suspicion, and we ordered for a CT scan initially. If you can see here, there is a very well circumscribed lesion in the inferior medial orbit. And on the sagittal section, you can see it is going down. This is nothing but the nasolacrimal duct. The lesion is going down into the nasolacrimal duct, and on endoscopic evaluation, we could see it at the inferior meatus. The lesion was removed in toto. So this is where your radiologist, if the radiologist is very experienced, they will actually give you a correct extent of the extension of the lesion as well. Here is another patient who presented to us with history of watering after a 3-point zygoma fixation. And if you see here, you can see that the screw that they have put is right at the lacrimal sac fossa area. So this patient, we did a CT DCG, that is a dactylar cystography, which comes in very handy. And if you see here, you can see this is the right, and you can see this is the left NLD. You can see the right NLD, and you can see the left side. You can see the dye is not going beyond at all. That means that there is a nasolacrimal duct obstruction because of this screw that has been put in here, whereas the dye is going very beautifully into the right sac. So this can be ordered in cases of traumatic or iatrogenic nasolacrimal duct obstructions. Here is another girl who came to us with history of proptosis and a decrease in vision, as well as squinting after a fracture repair. This is the CT scan of the patient. But if you see, we did an MRI here. Now, why have we done an MRI here is because the inferior rectus muscle was completely entrapped between the mesh and the globe. So now this is a case of an entrapped inferior rectus muscle, which could have been missed on a CT scan. So for soft tissue lesions, again, like I mentioned, you can ask for a MRI as well. Here, we specifically asked for a dynamic MRI because we wanted to know at what level is the muscle entrapped. Now, when you do MRI and when you want to look at any muscles, what is it that you look for? There are 3 things that you must look for in the muscle. A, of course, which muscle, whether it is unilateral or bilateral. B, how is the tendon? And C, the third thing is, how is the belly of the muscle? These 3 things you must look when you suspect any muscle involvement. So here is a patient who came to us with left eye ptosis and diplopia in upgaze and primary case. If you see here, we've done an MRI scan for him, and on T2, you can see there is a very well circumscribed lesion in the superior rectus muscle. There is a hyper intense lesion within the cyst, and that is nothing but a scolex. So this is a case of a superior rectus cysticercosis. Now here, a few other examples of the muscle involvement. Like I said, there are 3 things that you must see, whether it's unilateral, bilateral, how is the tendon and muscle belly, and how are the margins. Many differential diagnoses can be made based on this, like cysticercosis in the earlier case, like I showed you. Of course, thyroid eye disease, you can have metastasis, lymphomas, or even IOID myositis. Now here is a patient. As you can see, these are images of 2 different patients. On the right side, you can see that the lateral rectus muscle is involved, and even the tendon here is involved and thickened. But if you see here on the left side, you see this is a T1 weighted image with contrast. Now, why is this a contrast? Is because you can see that the muscles are taking up enhancement. So that is how you say, and contrast is always seen on T1. It's never seen in T2. So T1 weighted contrast imaging, you can see that the lacrimal gland, as you see here, compared to the other side, is quite enlarged. You can see there is some edema in the superior quadrant here. And you can see that the muscle is also not as finely well defined as here. So this is a case of IOID, which is involving the lacrimal gland as well as the lateral rectus muscle. Now coming on to one of the most common causes of muscle involvement, and that is thyroid eye disease. This young gentleman presented to us with lid retraction and proptosis of the right eye. We did a CT scan for him, which showed an obvious enlargement of the extraocular muscles, but clinically he was quite inactive. The CAS score was hardly 1. Now, if you do an MRI here, you can very well beautifully delineate that this is a tendon sparing involvement of the muscle, A, and B, there is activity in the muscle. So the muscle generally is iso-intense on T1 as well as T2. But if you see here, the muscle is hyper-intense on T2. So this is a case of active thyroid eye disease. And there is a sign that this sign is basically called as a Coca-Cola bottle sign because it's thin at the insertion and the belly actually swells up and is enlarged. So it's called the Coca-Cola bottle sign. Now, here is another case of an intraconal lesion. So like I said, how you start when you see a lesion, you compare both the sides and you see if there's some abnormality. So if you see here in all three sections, especially the coronal section down here, you see that there is a very well circumscribed intraconal lesion in the inferior quadrant, which is pushing the optic nerve little superior medially. You can see that the lesion is iso on T1 and it is hyperintense on T2. Now, this was a case of a very classical orbital schwannoma, but often on imaging, schwannomas and cavernous hemangiomas can be confused. And there is one classical sign that can actually differentiate between the two. And what is it? Contrast. So on contrast, you see that both these lesions basically are well circumscribed. They'll be iso on T1 and they will be hyper on T2. But the enhancement that they take generally is from the center towards the periphery in a case of cavernous hemangioma, as you can see here in the picture D. Whereas in case of a schwannoma, it might be a diffuse patchy enhancement or from the periphery to the center. Often you can have old long-standing schwannomas also having cystic changes, but this is one feature that distinguishes the two, that is the type of enhancement pattern. Now, this is another young child who presented to us with a nice strawberry reddish color lesion on the eyelid. And the mother said that when the child is crying, sometimes it becomes more prominent. So we went ahead and we did an imaging for this child. You can see here that you see a very ill-defined iso to hyper intense lesion on T2. And you can also see multiple flow voids within the lesion. So what is flow voids? If you see clearly, you can see these blackish spots within the lesion. That is nothing but flow voids. And this was a case of capillary hemangioma. Flow voids are quite classical of capillary hemangiomas. And this can be treated very well with oral propranolol initially. Now here is another patient. If you see here, he came to us with just history of double vision and prominence of the right eye. If you see closely, and when we did an imaging, he had a superior temporal lesion. I mean, he had an extraconal lesion in the superior temporal quadrant of the orbit. You cannot see the lacrimal gland, or you cannot see the superior rectus muscle or the lateral rectus muscle separately here. The medial rectus muscle, as you can see here in the axial cut, is well defined. Now, how is the lesion was basically heterogeneous. It wasn't homogeneous. As you can see here, it is hyper as well as iso in different places. Now, the catch here was that when we went in, we saw that the bone was not very good and not very healthy. So we repeated a CT scan here to be surprised to see that the lateral orbital wall and the roof was eroded. This turned out to be a case of adenoid cystic carcinoma. But the important point here is to also, when you're suspecting such big lesions, you can do a CT scan in order to see for any bony erosion, because sometimes these lesions might mimic a benign lesion also. So here is another similar case, which was that of a superior temporal, again, lacrimal gland lesion. You can see that it is again having heterogeneous intensity, but it is very well circumscribed. We did a CT scan here. You can just see a very subtle bony remodeling. There is no erosion. The inner walls of the orbit are very smooth. Okay, so this was a case of a pleomorphic adenoma of the lacrimal gland. Excuse me. Now, here is a young lady who presented to us with bilateral proptosis left more than right. She was being treated for conjunctivitis for the longest time. And if you see her closely, there's a very classical salmon patch that you see here in the left lower lid, I mean, the left inferior scleral area here. We went ahead and we did an imaging for her, which was suggestive of a lymphoma. Now, what are the classical features of lymphoma on imaging? Is basically that it will be iso-intense to hypo-intense on T1 and T2. Rarely it might be hyper, but most likely they're iso to hypo. And this is nothing but on the top right is a diffusion-weighted imaging. On diffusion-weighted imaging, there will be a high restriction. So there'll be a high ADC value that you actually see, and that is very classical of a lymphoma. Another interesting feature of lymphoma, if you see here, this is such a big mass here in the superior temporal quadrant. But look at the globe. The globe is very well intact. It is not getting indented at any point. So it molds around the globe and does not cause any indentation. So these are the classical features of lymphoma. And now it's diffusion-weighted imaging, which shows restricted diffusion, one of the clinching factors for also confirming the diagnosis of lymphoma on imaging. So that is that. Now here is a 6-year-old child who presented to us with history of fever and proptosis and chills. He also had movement restriction, and we sent him for a CT scan. He looked quite toxic. When we did the CT scan, as you can see here, okay, it was actually in the left eye. But when the CT scan was done on the right side, you can see that there is an involvement of the ethmoid and maxillary sinus, and there is some inflammation also along the inferior orbit as well as some collection. The lesion was on the left side, but the CT scan showing on the right side. So it is very important for us to check on a CT scan R and L that is often placed there. Sometimes it can be altered while giving the films. So we again repeated an MRI because we just wanted to confirm the level of the abscess. You can see that there is an orbital abscess along with an ethmoid and maxillary sinus, sinusitis. Also, when you have an abscess, the abscess is going to take up enhancement. It may be septate, and it will show restricted diffusion on DWI again. The ADC value is a little lesser than that of a lymphoma, but that is another feature of orbital abscess. So when in doubt, you can always go in and do a DWI imaging also and an MRI to confirm the same. Here is another patient. This is very classical, what Dr. Akshay was just mentioning that we have actually dealt with a lot. They're diabetic and came to us with sudden deterioration in the vision. If you see here, classically, you can see that this is a T1 weighted contrast enhanced image, which shows a lot of lesions in the sinus, the ethmoid and the maxillary sinus, but at the center of the lesion, it is not taking up enhancement. That is suggestive of a necrotic area. So this was nothing but a case of mucormycosis, and then she was treated by extensive debulking and amphotericin. That is the thing. So necrosis is often seen when you do a contrast. Area which is devoid of any blood supply will actually not take up enhancement, and that is suggestive of necrosis on contrast enhancement. Now here is another gentleman who presented to us with right eye proptosis and mild congestion in the right eye. He was being treated on IVMP and oral steroids, thinking that it's probably a thyroid eye disease or it is a IOID. If you see here closely, the MRI scan suggests of a very classical finding. You can see the extraocular muscles are enlarged, there is some inflammation, and there is a little fat stranding. But we repeated an imaging and involved the brain also this time. And what you see here at the level of the cavernous sinus. The right side cavernous sinus, the left side cavernous sinus is absolutely normal, but the right side cavernous sinus, there's a little asymmetry and there is some abnormal connection. On with contrast, when we did an MRI, you can see that there is an indirect CCF right here. So not all CCFs will show an enlarged superior ophthalmic vein, but it is very important for us to do a proper imaging and have a high index of suspicion in these kind of cases. Now here is a young child who presented to us with sudden onset of proptosis. If you see here, there is multiple fluid levels. There is a well circumscribed lesion here in the which is intraconus in nature, and it is showing it is heterogeneous in nature. It shows multiple fluid levels and multiple cysts, and this is nothing but a veno-lymphatic malformation which can be treated very beautifully with intralesional bleomycin. Here is another child who actually came to us with complaints. The mother said that whenever the child is like lying down and getting up, he's having a prominence of the eye. And whenever the child is crying, the child is having mild prominence. So what exactly is this case? This clinical evaluation is extremely important, and history is extremely important because it can often be missed by our radiologists as well, because the patients are generally in lying down position when we're doing the CT scan or the MRI. Now, if you see here the CT scan on the left side, the axial section, you can see that there is some small lesion in the superior orbit here, superiorly on the left side. And when we have done one simple test, you can see that there is proptosis. The level of the globe has changed. and you can see that the entire orbit is filling up. So this was nothing but a very simple Valsalva test, and this is a case of an orbital varix. Here is another patient with an orbital varix, but if you see here, there is a different density changes are there. One is isodense and one is heterodense in nature in the same lesion. So that is nothing but a thrombosed varix. So thrombosed varix can actually become hyperdense eventually. Now here is another child who came to us with progressive proptosis and squinting in the right eye. On imaging, this is what you see. Now, what do you see here? This is a sagittal section, T2 weighted image, and on my right is an axial section, T1 contrast. Here you see, you cannot see the optic nerve separately. Okay, you can see that there is a fusiform enlargement of the optic nerve, which is iso in nature, and it is taking up contrast in the axial section that you see here. So this is nothing but an optic nerve glioma, okay, wherein the nerve cannot be distinguished separately from the lesion. Whereas here, if you see, this was a young chap who came to us with progressive diminution of vision in the right eye. On imaging, you can see here that this is the T1 weighted contrast image on the left side, axial cut. You can see that the nerve is iso-intense along with the lesion surrounding it, which is hyper-intense. On CT scan, you might be able to see some calcifications along the lesion, along the nerve, and that is also having a classical name, and that is called as a cramp-back sign. So in optic nerve sheath meningioma, this is a case of optic nerve sheath meningioma. You see that the optic nerve is intact, but the meningioma surrounding that will actually take up enhancement, unlike an optic nerve glioma, which is the lesion of the nerve, and you'll have a fusiform enlargement of the nerve. So to conclude, I can go on and on, but to conclude, there are some lesions which are very classically seen as hyper-intense on T1, and some lesions which are hypo-intense on T2. Now, you can just remember simple mnemonic. My best friend is pretty cool. So M stands for melanin. Blood, if it is like subacute or little more chronic after 4 to 6 weeks, it will be hyper-intense. Fat or flow, like the venous flow that you see. Protein or paramagnetic substances such as copper and manganese. Cholesterol, and of course, contrast. All these things will be hyper-intense in T1. So PGs can just remember this mnemonic. My best friend is pretty cool. And lesions which are hypo-intense on T2 is basically, like I showed you, the necrotic tissue, the fibrosis. Any fibrosis will not be hyper, it will be hypo-intense on T2. Granulomatous lesions, metastasis may or may not be hypo-intense, but definitely calcium and air are hypo-intense. So I like to remember it as CAM-NGF. CAM for us was COVID-associated mucor, but here you can remember it as calcium, air, and probable metastasis. Also, when you see blood on imaging and MRI, based on the time duration that has gone past by, it actually changes its intensity and it can look different. And that is something that we all must be aware of. To conclude, how do you describe an imaging when you're asked an examination? Of course, you have to mention what type of an imaging it is. That is the CT scan or it's an MRI. Then you have to tell what part are you seeing, whether it's just brain and orbit, it's orbit and sinus, what are you seeing there? Third, you have to tell whether it is plane or contrast, which you can tell looking at the extraocular muscles or looking at any blood vessels if you can see that in the brain. Then if it's an MRI, you must also specify whether it's a T1 weighted sequence or it's a T2 weighted sequence, and then go on to compare. You can start from outside to inside or inside to outside based on how comfortable you are. I'd like to thank Dr. Veena, who is our radiologist, for this, and we've learned so much from her and our department. Thank you so much, everybody. And we can take some questions if there are any.
Thank you, ma'am. Very nice, very detailed, to the point, and very crisp. All common things are covered, all exam questions, everything is covered. To see if questions.
Sorry, I overshot the time a little bit, but
it's okay.
I think there's no questions.
Thank you. Thank you so much.
Thank you so much.
Have a nice Sunday, everybody.
Yeah, thank you.
And this is a fabulous program. Thank you for this. All our PGs are also attending, and I've got really good reviews so far from all of them. So thank you again.
Thank you.
So shall we go to the next?
Yeah, I think we'll go to the next.
Next, Dr. Arun Varghese will introduce Dr. Firos. I will share the screen.
Good morning, everyone. We are indeed privileged to have Dr. Fairouz speak, who is going to speak to us on lid tumors and their reconstruction. Dr. Fairouz is well known to Kerala ophthalmologist. She's did a basic graduation from Thrissur, then PG from Mysore, and then she did a fellowship in Oculoplasty and oncology in LV Prasad Eye Institute and Wills Eye Hospital, and then Shiley Eye Institute, San Diego, USA. We all know her familiarly as she's in the All India Ophthalmic Society member of the scientific committee. And I understand she's also vice president of the Asia Pacific Ocular Oncology Pathology. She's also a section editor for the IGO of Ocular Oncology and Pathology. And also, she, as you know, she's got numerous publications and has won numerous awards at the All India American Academy of Ophthalmology. I remember once saying that she once won a hat trick of awards, 2014 to 2016, and I can see she also won the best poster in 2017 and 2021 as well. So she's a well acclaimed ocular oncologist, and she's also in the top 100 women ophthalmologists worldwide. We're indeed privileged to have you giving, as you know, the February 4th was the World Oncology World Cancer Day. And Dr. Fairouz will be giving us the World Oncology lecture on focusing on lid tumors and management with special emphasis on lid reconstruction. Over to you, Dr. Fairouz.
Thank you so much, Dr. Thomas, for this kind introduction. And thank you, Dr. Marian. Thank you, Dr. Shebin, for having me here. And as always, Cochin Ophthalmic Club. It's a pleasure to be part of your team in all these academic endeavors. And today, I think I'm really happy to be here because it's a postgraduate teaching program. It's really wonderful to interact with the PGs because definitely you are the people who's upcoming and, you know, doing much, much better than what we are doing at this point of time. So I'm going to share my slide over here. Okay, 1 second. Sorry. There is some issue with my sharing. I'm really sorry, Marian. Just give me a minute. I've opened it up, but it's not getting. Just a minute. I've recently updated my laptop. I don't know whether that's the issue. Just a second. Just try once. Marin, is the other speaker around? I just don't want to waste
no
time.
problem. Then I think I will speak about thyroid.
Yes,
Dr.
Marian.
Shebin.
Yeah, I think there is a problem with the sharing of the screen. I just.
Ma'am, or else if it is not working, I'm sending you my mail ID. If you send
Okay, can you play it? Yeah.
Yeah, I'm WhatsApping my mail ID.
Okay, perfect, perfect. Yeah.
So now I think we will move to the next one now.
Maria ma'am, you are presenting next.
Yeah, I will present thyroid. Meanwhile, we can sort out this thing. Okay.
Okay, ma'am. Dr. Marian does not need an introduction. She's the HOD of Oculoplasty department at present, Girdhara Hospital. She's also the scientific committee chairperson for the Cochin Ophthalmic Club currently. To you, ma'am. Thank you.
Yeah, my slides are visible, right?
Yes.
Yes, Maria.
Should go to the slide.
Okay. Yeah, okay. Thank you, COC. So thyroid eye disease for postgraduates is a very, very important topic. In fact, I was going through the old 5 years, 10 years question paper, and almost every year you're having one question. So these are some of the questions asked in the last 5 years. Etiopathogenesis, clinical features, grading, management, both surgical, medical, then differential diagnosis. So all aspects of thyroid eye disease are very, very important. And in my next 20 minutes talk, each slide is an answer. As we know, in DNB exam, it's a 3-hour session with the 10 questions. So you will get 18 minutes for each question. So in this next 20 minutes, hope I will be able to do justice to this topic. Thyroid-associated ophthalmopathy is an organ-specific autoimmune process. It can precede, coincide, or follow the complications of dysthyroidism. So in this slide, only 2 sentences are important. It is more common in females, but more severe disease in males. So this is, please remember, even though it is very common in females, severe disease occurs more in males. Then what is the status of thyroid in thyroid-associated orbitopathy? Obviously, Graves' disease, 80% of patients with thyroid eye disease will have Graves' disease, followed by euthyroid in 6%. Rundle's curve, this is a very, very important question for in the exam. It's a curve that determines the natural history of thyroid eye disease. So in the first phase, it's an active phase, then it goes to a static phase, then it's a quiescent phase. So in the active phase, you can get all the complications. In the static phase, the disease is static and you'll wait for 6 months or 1 year. And then the quiescent phase, you think about cosmetic rehabilitation. The next is prognostic factors. I have put 8. These 8 factors are important in theory as well as when you assess the patient. One is the antibody levels, history of radioiodine treatment, genetics, mean any family history of thyroid eye disease or even dysthyroidism in the family, history of smoking, male sex, age, history of diabetes, and any kind of stress. These are all 4 prognostic factors in thyroid eye disease. This is another question, pathogenesis. Even though it looks little complex, I have made it a very simple. So we know it is an autoimmune disease. So first you write it's an autoimmune disease where increase in the size of extraocular muscles fat occurs due to cytokines, immune cells, autoantibodies, and environmental factors. So what exactly happens? What are the antigens? There are 4 antigens detected. One is thyroglobulin, second is Ptosis receptor antibody, then IGF-1 receptor, and extraocular muscle antigens. This the autoantibodies will act on fibroblast and it causes activation of fibroblast. So once fibroblast is activated, it will not sit like idle. It will release chemokines. So what the chemokines will do, it will recruit T lymphocytes. So after this much happens, these two will become friends. That is, fibroblast and T lymphocytes will interact together, and it will lead to again secretion of cytokines. They are inflammatory markers leading to glycosaminoglycans, fibroblast proliferation, and adipogenesis, leading to all the clinical findings in thyroid eye disease. So in pathogenesis, basically you should remember all the antigens and the basic pathologic mechanism, that is fibroblast activation. Coming to the clinical features. Clinical features are divided into lid features, then orbital features, and optic nerve involvement. So there are so many named signs in thyroid eye disease. We know, even like it's literally very difficult to remember the names, but at least the signs we can remember. This is very easy. When you look at the patient, what all things we look? We look at the eyebrow, we look at the forehead, we look at the eyelid, we look at the glow. So in the lid retraction. This is an exam question. What are the mechanisms of lid retraction? So one, proptosis. When the globe is proptotic, naturally the lid will go up. So that is one reason. Two, sympathetic drive of Muller's muscle. We know thyroid hormone causes sympathetic stimulation. This stimulates Muller's muscle and causes retraction. So if you remember this mechanism, it is very easy to manage lid retraction. Okay. So third is fibrosis of the levator. What will happen in fibrosis? It will fail to relax, so it will go for retraction. Then contralateral ptosis, if there is an associated myasthenia. Then adnexal fibrosis, inferior rectus fibrosis also can cause a retraction. Then contraction of lower retractors and superior rectus. So these are main important mechanisms for lid retraction in thyroiditis. Next is von Grafé sign. That is when you look down to turn descent of upper eyelid on down gaze. Coker's sign is a staring and frightened look. Fullness in the lid, Vigorok sign. Ballet sign is movement restriction. For convergence is Mobius sign. These few signs I have put, it is easy to remember. Retraction, staring look, lid lag on down gaze, eyelid fullness, ocular motility restriction, and Mobius sign. So there are so many other signs. I'm not going into the details. So next is proptosis, then soft tissue involvement. So gold Caesar sign is there is deep injection of temporal conjunctival vessels over the recti insertions and chemosis. Cornea, you can have everything, starting from SPKs due to lag of thalamus and exposure. Then in the superior conjunctiva, you can have superior limbic keratoconjunctivitis, corneal exposure, leading to infection. That is corneal ulcer. So all these things you need not mark up. Actually, you can remember in the sense it's logical things. What are the causes for exposure keratopathy in thyroid? One is proptosis, lag of thalamus, lid retraction, infrequent blinking, then absence of wells due to inferior rectus tethering, and finally dry eye due to lacrimal gland involvement as well as increased surface area due to proptosis. So these are the 6 causes for exposure keratopathy in thyroid. This is one of those favorite question of examiner. So now coming to restrictive myopathy. First, inferior rectus is affected. It followed by medial, superior, then obliques, and then lateral rectus. So lateral rectus is affected last, and it is relatively very uncommon in thyroiditis. Then you can get lacrimal gland enlargement, choroidal folds. Then on the forehead, you can get deep labella guided rhytids and glaucoma. Glaucoma can be either ocular hypertension, which is associated with the glaucoma, or it can be an associated primary open angle glaucoma or secondary open angle glaucoma. Now coming to the next part, that is, which are the classification systems in thyroiditis. Various classification systems are described. Don't worry, these are all very easy to remember. So I have put 4: NOSPEX, HAS, UGOGO, VISA. NOSPEX is proposed by Werner, or in other ways it's called Werner's classification. CAS or clinical activity score put forward by Maurice et al. UGOGO is European Group on Graves orbitopathy classification. Then VISA classification by Dolman Group et al. So I will just mention what are the pros and cons of each. So Werner's NOSPEX, it's a mnemonic. N means no signs or symptoms, or only signs. S is soft tissue, P is proptosis, E is extraocular muscle, C is corneal involvement, and S is sight loss. And each is divided into absent, mild, moderate, severe, marked, and severe. So this is very easy to remember, NOSPEX. So what are the limitations of this? here what happens is all patients do not progress through all stages. That means all patients will not land up in any sight-threatening diseases. Second, it doesn't have any prognostic or treatment implications. This was one of the first classification. So that is why other classification systems came up. So now come to the clinical activity score. So basically in thyroid eye disease, we have to know, we should assess the patient to see whether this patient requires any treatment or not. So disease phase is assessed by disease activity and severity, determined by clinical activity score. So what do we mean by an active disease? As the name implies, it has got inflammatory features. So you can see in this, and this will respond to anti-inflammatory therapy. So it is very simple. So what is inactive? So if there is an active phase, naturally it will have an inactive phase also. So in that case, you can have fibrosis with secondary effects, but no evidence of any inflammation. So this is the same patient showing active phase in the left eye, and after treatment, reach the inactive phase in the left eye. So how do you assess clinical activity score? So 4 parameters: pain, we have heard about Thaler, Huber, Dollar, etc. So in accordance with that, pain. So where you can get the pain? It's either orbital pain or ocular pain, or pain when you look up and down. Then redness, where all either in the lid or in the conjunctiva. So redness in the lids or redness in the conjunctiva. Then swelling, again conjunctiva and lid. Swelling of eyelids, chemosis, swollen pharyngeal. So when the swelling happens, what will happen? The globe will move forward. So increase in proptosis of more than 2 millimeter. Then impaired function. So as an ophthalmologist, we know our main aim is to save or preserve the vision. Or so in this case, decrease of vision acuity of 1 line on the Snellen chart, or decrease of eye movement in any direction 5 degrees. So this is the 2-3 parameters we look in the impaired function. If the score is 3 or more, it is considered as an active disease. So this is one patient. So this patient, clinically, when you look, there is no redness, no chemosis. But when you assess the clinical activity score, he has got pain, he has got double vision, which is increasing, his vision is threatening. It's an active disease. Now coming, so once you decide the activity, now you have to see how severe is the disease. UGOGO, that is European Group on Graves Orbitopathy, categorized the disease severity into 3. So 1 is sight-threatening thyroid eye disease, 2 is moderate to severe, and 3rd is mild. So what do you mean by sight-threatening? As the name implies, the sight is threatened. That means the patient will have either optic neuropathy, or the globe is out, that is eyeball subluxation or choroidal force, or with or without corneal breakdown. So this condition requires an immediate intervention. So coming to the second category, moderate to severe thyroid eye disease. Here, this patient does not have any sight-threatening disease, but they have got problems that got sufficient impact on the quality of life, which requires rehabilitative surgery or immunosuppression or orbital radiation. So here, if the lid retraction is more than 2 millimeters or proptosis more than 3 millimeters, then moderate to severe soft tissue involvement, intermittent or constant diplopia. So these patients, they don't have any vision, sight-threatening disease, but they need treatment. So that is moderate to severe thyroid eye disease. Coming to mild TED, here very minor impact on the quality of daily life. That means it is not really affecting their life, routine life. So we need to observe them. Vitral waiting is appropriate, and risk of immunosuppression or surgery is not justified in this group unless if there is progression. So in this category, there is a minor lid retraction, less than 2 millimeters, mild proptosis, mild soft tissue involvement, no diplopia, and mild few SPKs, but it is better with lubricating drops. But if it is, you keep the patient under follow-up, and if it progresses to moderate to severe thyroid eye disease, it needs treatment. So this is the UOO classification. Now coming to VISA classification. V stands for vision, I for inflammation, S for strabismus, and A for appearance. These are also again categorized, and score of 5 or more is considered as active disease. So now we have seen Werner's classification or NOSPECS, then clinical activity score, UGOGO, and VISA. There is one more classification is there, which I have not included in this relief classification, but it is not at all used nowadays. So these are the main 4 things, and usually they put 4 marks. So 1 mark for each category. So coming to the next topic, next subdivision, that is differential diagnosis of thyroid eye disease. So one is orbital cellulitis, orbital inflammatory disease, thyroidic cavernous fistula, then any causes of thickened ocular muscles, that is sarcoidosis, metastasis, lymphoma, amyloid, and viral conjunctivitis. So here the main thing is to differentiate from orbital inflammatory disease. So thyroid usually bilateral, can become unilateral also. It starts as unilateral and then become bilateral. But IOAD mostly unilateral. Thyroid pain is very minimal, but they'll have more pain. And in thyroid, muscle belly is involved, sparing the tendon. In orbital inflammation, both muscle and tendons are involved. And the main thing is usually thyroid will have retraction, whereas orbital inflammatory disease, they present with ptosis. But it's not a clear-cut differentiating feature. It can happen either way. And another thing, lateral rectus involvement in thyroid eye disease is little rare, whereas it's common in orbital inflammatory disease. I'll just put a case just for the understanding. This is a 59-year-old male with a hyperthyroidism, status post thyroidectomy, presented with a defective vision in the right eye. You can see 6/36 in the right eye. Fields are little defective in the right eye. So we have done the fields, then OCT nerve fiber layer analysis also done. We can detect early edema, then thinning, and it's an adjunct to visual fields per se. And it needs treatment. This is another patient, again with compressive optic neuropathy. You can see the disc edema, choroidal folds, congestion, chemosis, fullness, edema, etc. These patients require treatment. I just showed just to show the clinical features. Now come to the orbital imaging. When all vision threatening disease needs an imaging. Moderate to severe disease, then to rule out orbital space occupying lesions, to confirm or diagnose euthyroid ophthalmopathy, then before decompression, and to rule out the other differentials. We have already seen now CCT, thyroidic cavernous fistula and cavernous sinus thrombosis can be differential to rule out the cavernous sinus, other differentials. Regarding the imaging, we have heard in detail from Dr. Sona. The lab studies, we go for pre-T4, TSH, and thyroid antibodies. Specifically, we can ask for TSH receptor antibody. Coming to the management, once you diagnose thyroid eye disease, get an endocrinology referral. Even though it reduces orbit-directed autoimmune reactions, it might not alter the course of existing thyroid eye disease, but still you have to refer to the endocrinologist for the management of dysthyroidism. Various regimens are available. No, even though it is not under the purview of ophthalmologists, but we should know either it is block replacement regimen or titration regimen. So now coming to the treatment of eye disease per se. Always give whatever stage of the disease, supportive treatment in the form of lubricants, head elevation, sunglasses. Then always ask for the history of both active and passive smoking. If so, ask them to stop smoking. Coming to the medical management. We all know steroids are the most mainstay of treatment. The steroids can be either oral or intravenous. So oral steroids, 1 milligram per kilogram per day, taper to 20 milligram over a period of 3 to 6 weeks, and then slowly taper over a period of 24 weeks. Because if you taper very fast, the inflammation can come back. And 45 to 83% of patients have favorable effects. Coming to pulse therapy, it is named after J.J. Kahali, that is Kahali's regime. Here, 12 weekly infusions of methyl prednisolone, that is 500 milligram weekly for 6 weeks, followed by 250 milligram weekly for another 6 weeks. So it gives a cumulative dose of 4.5 grams. So studies proven that up to 9 grams, like 7.5 to 9 grams can be given without much complications. However, you need close monitoring of hypertension, diabetes, and liver function test. The next step is steroid-sparing therapies. The drugs used are cyclosporin, methotrexate, azathioprine, mycophenolate, mofetil. Coming to orbital radiation, what are the indications? Indications are, it is given in steroid responsive compressive optic neuropathy or in steroid responsive active disease. Second, it can be an alternative to acute phase decompression or prolonged use of steroids, especially in patients with contraindications for long-term steroids. It is given as 10 fractions in 2 weeks, 2000 centigrade. How it acts, it stimulates lymphocyte apoptosis. So we have seen in pathogenesis, like, the cells involved. So it stimulates lymphocyte apoptosis, and second, promotes progenitor fibroblast terminal differentiation, leading to decreased deposition of glycosaminoglycans. So that's a mechanism of action in orbital radiation. No need to mug up all these things. When you think about the treatment, think where is the pathology, because you are treating the pathology. So this is a case example. Thyroid eye disease, we have treated with immunosuppressants, methyl prednisolone, and orbital radiation. He had compressive optic neuropathy and he did well. It's a combined treatment. This is also another case example where we have managed with steroids, immunosuppressants, and orbital radiation. So another fourth category is, like now we are treating many of the diseases, especially in uveitis with biologics. So similarly, in thyroid eye disease also, biologics has come up. One is teprotumumab. It is directed at IGF-1 receptor. Tocilizumab at interleukin-6, and rituximab is a B-cell depleting anti-CD20 monoclonal antibody. So just remember these three names can be useful in viva as well as in theory. So this is a gold medal slide. There are 2 clinical trials related to thyroid, recent trials. One is STAGO, that is status for Graves' orbitopathy, to see whether lowering of cholesterol levels with statins can have a better outcome in thyroid eye disease. Second is OPTIC trial, that is treatment of Graves' orbitopathy to reduce proptosis with teprotumumab infusions in a randomized placebo-controlled clinical study. So just remember these 2 names. STAGO, we are seeing statins. In OPTIC trial, it's almost done, and using teprotumumab. Coming to the final part, that is a surgical management. Just remember this OC, that is orbit, squint, and eyelid. So when you think about surgical management, first think about the management of orbit, that is proptosis or the optic nerve. Second is squint, third is eyelid. I'll just run through the important points. So one is orbital decompression. So either it can be acute phase decompression or a stable phase decompression. Then depending on the timing, depending on the structure, either it can be bone removal decompression or fat removal or combined. So we'll see. Acute phase, that is optic neuropathy, not responding to medical treatment. Endoscopic medical decompression, medial decompression is done with or without lateral bone. Stable phase, basically cosmetic or to reduce proptosis. When disease is stable or the clinical parameters are stable for at least 6 months, stable endocrinologically also, and we are not planning to change any treatment now. In that case, we can do stable. That is called stable phase decompression. Before going to the types of, there are 3 groups we have from the decompression point of view. So group one is normal extraocular muscle, fat is enlarged. Group 2, like opposite, that is extraocular muscle is enlarged, fat is less. Group 3 is combined. So the decompression also depends on this. These are the clinical picture. Here, see, you can see muscle is not clearly very enlarged, but gross fat is enlarged. In this, you can see the fat is less, but muscles are enlarged. This is combined. Get the older photo also, how the patient was before deciding on decompressions. So indications for decompression, in fat-only thyroiditis with moderate TOM limitation, moderate proptosis, lateral or medial wall with fat, moderate extraocular motility restriction with severe proptosis, combined medial and lateral wall in severe proptosis. This is the basic guideline. Little controversy in this also. Fat alone, some others say only 2 millimeter reduction. Some people will say 3 to 4 millimeter. That again depends on the type of disease patient is having. Then fat with lateral wall can have up to 6 millimeter reduction of proptosis. 3 wall, like medial lateral fat, can get 8. And if you remove the intranasal wall, that is flow, more than 8 millimeter reduction in proptosis. Nowadays, balanced decompression is practiced, that is both medial and lateral wall. It offers increased efficacy with less complications. Coming to strabismus, to manage strabismus, either you can use prism glasses or surgery. We give prism glasses when there is Ectropion primary gaze and reading position, then inactive phase and measurement stable for 6 months. Surgery also, if the patient is not happy with the prisms, and patient is stable endocrinologically, stable parameters, you can think about surgery. Surgery is either recession of inferior and medial recti with adjustable sutures. Botulinum toxin is controversial, but sometimes you can try that also. Coming to lid surgeries, like we have seen from the signs, that is puffiness of the lid, retraction of the lid, and lag of thalamus. So blepharoplasty can be done to correct the puffiness. Then for the lid retraction per se is a 10-mark question in exams, mechanisms and management of lid retraction. So management broadly divided into surgical and non-surgical. Non-surgical is filler, injection triamcinolone and botulinum toxin. Surgical is look at the structures which is causing retraction. Muller's muscle, levator muscle, lid per se. So mullerectomy, levator recession, blepharotomy and scleral spacer. Just few words. Hyaluronic acid filler is used. It is given either transconjunctival or transcutaneous. This is one patient post-filler injection. He was not bothered about his proptosis in this case. This is also another patient post-filler. Then botulinum toxin can be given. Triamcinolone is given to the levator muscle. It is given transconjunctivally. Coming to the surgical management, mullerectomy can recess the levator, then blepharotomy and the scleral spacers can be done. Then tassorrhaphy also can be done in exposure keratoquery, or in case of mild scleral show, you can do a small lateral tassorrhaphy. So this is in a nutshell about thyroid eye disease, like pathology, clinical features, classification systems, then management. So to conclude, it's a very highly stigmatizing disease. It's a multidisciplinary approach, and control of inflammation remains the most important. And there are new therapies also emerging. This is our team. Thank you.
Very detailed class, ma'am. I think nobody can miss any questions from thyroid.
Yeah, that's what I wanted to, PGs should never miss. Everybody should get 9 marks out of 10 in thyroid eye disease related questions.
Fantastic, Marian. It was a revision for me also, actually. Yeah, so good that you put that gold medal slide.
Yes, gold medal
regarding the trial. I think we can add one more to it. I'm sure you know it.
Yeah.
It's the Mingo trial.
Yeah, I forgot. Actually, I had it today morning.
So the Mingo trial is where mycophenolate mofetil was, used as an immunosuppressive drug in thyroid. So they compared the use of mycophenolate mofetil and IVMP versus only IVMP. So so that is also
thank you.
Can write down.
Thank you for adding to that.
Yes.
Iris, you are sorted out now?
Yes, sorted out. I'm so sorry. Apologies to everyone, including
Not
the students. Yeah.
Please go ahead. Thank you.
All right. All right. Yeah, once again, thank you, COC and Marian. So this is one of my favorite topic, and I will be taking you through eyelid tumors and principles of management. What I miss in these online sessions, especially the teaching programs, is that we not able to interact with you postgraduates, which takes half of the fun out of this session. Anyways, so we will keep it mostly practical, case oriented, so that you see things and it's easy for you to remember rather than going into the theoretical part of it. So these are my previous and current affiliations, and I'm extremely grateful for my team who has made this practice of ocular oncology easy and smooth. It's very important as postgraduate students. I'm sure, you might get short cases or an OSCE case where you have to give a quick diagnosis. And theoretically, I have seen various DNB question papers and MS question paper. In my MS exam, I had a 10 marks question on eyelid tumors. So it's although a very diffuse subjects, it's very, very important to know major aspect of it. And also in your clinical practice, you need to know the basic things where you can identify a benign lid lesion, an inflammatory lesion from a very bad malignant lesion, because there are eyelid tumors which are very lethal, and it can cause regional lymph node metastasis, systemic metastasis, and even mortality in patients. So very, very important to identify this. So I have given you array of pictures over here, A, B, C, D, E, F. So, if we're interacting, it was much easier to get your input on different images over here. So, I'm going to go to the next slide over here. So basically, what we see this is definitely, a papilloma, a papillomatous lesion, slightly pigmented. It doesn't have any features of a malignant lesion, so it is benign. But this definitely has features of malignancy. Why do I say that? Because there is a lesion over here, and there is ulceration over the lesion. There is loss of lashes over there, and there is actually a deformity in the eyelid where you can see that the tumor is eating up the tissue. So this is a basal cell carcinoma of the lower lid. This is a happy lesion. It's a very straightforward nevus sitting in the eyelid. Now, what about this one? It appears to be large, but not much of vascularity, white in color. It's a cystic lesion. It's an hydrocystadenoma. Now, this is a very important thing that you need to know. So eyelid tumors, it's not only the anterior lamellae that you have to examine, you have to actually avert, whether it's a lower lid or whether it's the upper lid. Any lumps or bumps in the eyelid, you have to always avert the eyelid to see the posterior lamellae also, because there are important cancers which can arise from the tarsus, from the glands, and from the posterior lamellae. And this is one such, which is called the sebaceous gland carcinoma of the eyelid. And this is a very lethal eyelid malignancy. Now, the last one is very important. Most of us, come through these. These patients sometimes present as blepharitis. And blepharitis is something that we see commonly in our practice. Usually, blepharitis is bilateral. So whenever you find a unilateral blepharitis, which is kind of asymmetrical, even unilaterally, you should always think of something which is spreading in the skin and the conjunctiva. And what is the two things that I would keep in mind would be a sebaceous gland carcinoma, again presenting as a vegetoid spread, or even a squamous cell carcinoma, which can be diffuse. All right. So these are the bad lesions over here. And the features are very, very striking. They're all decent tumors over here, sitting in one corner, causing no destruction. But these are all large nodular ones causing destruction. So the common benign eyelid tumors, depending upon where they arise from, the cells that they arise from, the lamellae that they arise from, the etiology, they are classified into various things. So this is the area of tumors. So, not that all tumors, even benign tumors, require surgical intervention, excision, or eyelid reconstruction. These are the common ones which can be treated without any surgical intervention, conservative management. And this was a child who presented with a hemangioma. All right, an infantile capillary hemangioma of the eyelid. And this is conservatively managed. You can see from the day 47 to day 30, where the child was on topical timolol maleate and also oral propranolol. So this was how the patient presented initially, and this is how the child was after 4 months on completion of tapering of oral propranolol. And the dosage that we usually start is 2.5 milligram per kg body weight after having a thorough baseline evaluation of the child's systemic and cardiac status. And always remember that it has to be tapered, because it can cause, if you don't taper the oral propranolol, there can be recurrence. It's 17% is the reported recurrence in oral propranolol treatment in capillary hemangioma. Again, conservative management in eyelid tumors. So what you see here is actually a lump or a bump sitting in the lower eyelid over here. And then she has been noticing it for the past 5 years, associated kind of an aching pain. And, we did Valsalva maneuver. It was found to be an eyelid varix, which is a vascular malformation of the eyelid. And the only thing that we did is, whenever it's vascular, you try to avoid surgical intervention, because we all know that it's going to bleed. And fortunately, now currently we have so many things in our hand, injections, tablets, and oral preparation where these can be treated. And what this patient was treated with was injection bleomycin. And this is just one session of injection bleomycin, into the lesion. And this is how the outcome is. It is completely resolved. So there are benign lesions, yes, for cosmetic improvement, and also to have a histopathological diagnosis, we go for excision. So this is a kissing nevus where you can see a nevus in the upper lid and the lower lid. So with simple procedures like, if I have an eyelid nevus sitting in the edge of the eyelid, the only thing that we need is to go and shave the lesion. It's called the shave excision biopsy. You don't even have to go for a full thickness excision or anything. And similar thing was done even in this large lesion, which is almost covering half of the upper lid and the medial 1/3 of the lower lid. What was done was to strip this lesion very superficially along with the epithelium of the anterior lamella, the skin, anterior lamella of the eyelid, which is the skin, and the shave excision biopsy of the lower lid. And this is how you find it. In fact, no graft was done, and this was left for second intention healing. This is actually after 2 months post-operatively, and now it looks much, much better. I have not put that picture over here. Larger lesions, which looks very large, which worries you, but it doesn't have any malignant features as such. It's kind of a very stuck-on appearance, absolutely no feeder vessels. So any part of the body, any portion of the eye, whenever you differentiate a benign lesion from a malignant lesion, the first and foremost thing is to look for a large feeder vessel. Any dilated tortuous vessel, which has all the tumors, the malignant tumors, in order to rapidly progress, needs oxygen, needs blood supply. So there will be a large vessels serving it. But such lesions, although it looks very bad and large, it doesn't have any feeder vessel over here. It is a benign lesion, and this is a seborrheic keratosis. All right, but it requires excision. It's growing, it's progressing, and it's a large lesion. So this is the complete excision of the lesion in order to prevent recurrence. And well, when you excise a larger lesion in the eyelid, there is definitely going to be a large defect. So in older patients, they will have some amount of dermatochalasis, where otherwise, a blepharoplasty would have helped cosmetically. So for the skin graft, we have many options. We can have retroauricular graft, we can have supraclavicular graft from the medial portion of the arm. But the best option, as much as possible that you can think of, especially in older patients, is to take skin from the other side, which will cosmetically benefit her for the right eye. So a skin graft was taken via a blepharoplasty of the right eye, put over here and reconstructed. And this is how she looks after excision and healing. Now, most importantly, it's the malignant eyelid tumors. There are known malignant eyelid tumors. There are very rare malignant eyelid tumors. So, well, basal cell carcinoma is something that we come across in our clinical practice. Yes, to a certain extent, squamous cell carcinoma and sweat gland carcinoma, which is very, very rare. It can present and mimic a benign cystic lesion to a greater extent. So it's always good to excise these lesions, and sometimes it can give you surprises. I'm going to discuss with you regarding my surprise. And keratoacanthoma is currently considered as a low-grade squamous cell carcinoma, although it is not a very aggressive malignant eyelid tumor. Now, these are the important eyelid tumors. You should never miss it. You should never go wrong in the management of these tumors, because it can be deleterious in future. So the most lethal eyelid tumor, and this is in chronological order, is Merkel cell carcinoma, malignant melanoma. It can be primary, arising from the eyelid, or it can be secondary, where you have a melanoma in other part of the body and then it spreads to the eye, and sebaceous gland carcinoma. And this is exactly how they look like. Sebaceous gland carcinoma usually has a yellowish color because it's arising from the meibomian gland. Posterior lamella will be involved. Melanoma is purely a skin involvement, that is anterior lamella. It will be brownish in color. Merkel cell carcinoma is extremely vascular. It will be reddish in color, and it has a very fast progressive growth. So any reddish in color, don't think that it's a benign hemangioma and keep waiting or observing the lesion, especially in older age group. Always excise it. It might surprise you, although it's very, very rare. I agree. And this is an adenocarcinoma, very vascular tumor, again in an older patient. It can be primary, it can be secondary. There can be an adenocarcinoma sitting somewhere in the body and then spreading to the eyelid, or it can be primarily arising from the eyelid. All right. So these are very important things, guys, that you have to remember. So what are the red flags? Whenever you see an eyelid lesion for your exam or in your OPD, in a busy OPD, never miss these things. First, from the history, you have to see whether it's a rapidly growing tumor. Mostly rapidly growing tumor is malignant, but of course, basal cell carcinoma can be a very slow growing tumor, but it will be eating up the surrounding tissue and the eyelid. Mostly the malignant tumors are firm. It will be nodular. There can be surface ulceration. There will be bleeding. Lash loss is very, very important thing that you have to look for. If there is lash loss, there is definitely a red flag. Intrinsic vessels, feeder vessels, which I've already told you. And always make sure that your examination doesn't end with the detailed evaluation of the eye. All right, you have to always go and look for lymph nodes if there is a suspicion of malignancy. The preauricular lymph node, the submandibular lymph node, the anterior cervical, and the posterior cervical ipsilaterally, which is very, very important. Now, this is a patient who presented with this large lesion. In fact, he gave a history of a rapid growth. All right. So it looks benign. As I told you, there is no vascularity. The lashes are very well intact. It's arising from the anterior lamella. Cystic, well, it could be a hydrocystadenoma or a syringoadenoma, or rarely it could be a malignant lesion also. So I'm very, very careful in these situations. Now, something that you should always, look is for a transillumination, whether, to know whether it's a cystic lesion or a solid lesion. And this was a transillumination test done. Of course, it is very, very cystic, but you can see these vessels, which I was actually not happy about about. So I told the patient that there is a possibility of a malignancy, a very rare possibility of a malignancy. And I'll tell you why, because I learned a lesson with a lesion. And then, a total excision was done. But fortunately for the patient, this came out to be a syringoadenoma. But syringoadenoma can also turn malignant. It can also turn into a syringoadenocarcinoma. So this is a lesion, a lady, a long-standing lesion. In fact, 2 years back, she had this small, tiny cystic lesion, which she was seen elsewhere. And, what she told me was like someone pricked it, the fluid came out, and then it became flatter. But in subsequent 2 years, this has been growing. And for the past 2 months, she noticed that it is rapidly growing. Of course, if you see this lesion, it's very cystic, like how I showed you the previous case, all right? And that came out to be a syringoadenoma. But compared to the vessels of that, although there was one vessel which was like kind of dilated, there is multiple, and this is a large feeder vessel over here. You can see intrinsic vessels, everything. So something fishy in this particular case. In fact, we went ahead, taking margins, frozen section, etc., a deep dissection, and it came out to be an endocrine mucin producing sweat gland carcinoma in this patient. In fact, this is a very, very rare malignancy. Axial has reported one case in IGO, I remember, but very rare. And this is also associated with breast carcinoma. So, whenever we get this tumor, we also systemically evaluate any malignancy. Anyways, we evaluate them systemically after the diagnosis comes. But this particular, we had to do a mammography, ultrasound of the breast to rule out carcinoma of the breast because there is association. So this is how varied the tumors are. So never take a lump or a bump in the eyelid too light. You can have surprises and it can turn out to be something really, really rare. Now, this patient presented with this lesion, a nodular lesion. You can see this, crater in the surface. There is ulceration. Well, not much of a lash loss. It's growing into the posterior lamella. So seeing this again, the antenna of suspicion arised. And I, in fact, went for a frozen section with margin clearance, etc. Looking at the clinical appearance, keratoacanthoma was something that I kept in mind in the diagnosis. But again, this is the histopathology. It was totally benign. There is no blue cells. There is no atypical cells in this lesion. And this came out to be a nodular hydroadenoma. So very rarely, some of the benign lesions can also give you a surprise as a malignant lesion clinically. All right. Now, this patient was referred to me as a case of sebaceous gland carcinoma, to rule out sebaceous gland carcinoma. Chronic blepharitis, as you can see here, right eye is absolutely fine, but severe blepharitis in the left eye. And as I told you initially, an asymmetric blepharitis, unilateral blepharitis, always we keep in mind about sebaceous gland carcinoma. But you can see here, there is a lump in the upper lid also. In fact, he had a granuloma in the upper lid. Now, I'm going to show you how it looks like. Okay, very, very lumpy, bumpy. It has a granulomatous appearance. There is nodules over here. The entire posterior lid margin is destroyed. It's distorted. It is rounded. But if you see, there is not much of very prominent feeder vessel, which is kind of, a relief when you think about the patient. So I didn't go for a complete excision in this case. It's a very diffuse lesion. So you'll get a very good amount of ample incisional biopsy. So an incision biopsy was done from this part. He had a preauricular lymph node, okay, in the ipsilateral side. And sorry, I have not put the picture of the upper. It was something like a chalazion, which was sitting in the upper lid also, posterior lid granuloma, all right. Now, so a lymph node biopsy was also done. It came out to be necrotic granuloma and also an AFP positive. So this was a tuberculous granuloma in the eyelid, very rare. And that's how it was destroying the eyelid, architecture. And he underwent ATT and treatment locally, and then he completely resolved. All right, now this is something that I really want to highlight over here. A very classical presentation in an old age lady where, they would come with kind of a nodular lesion, multiple history of incision and curettage, thinking of a chalazion. It's not too difficult to identify a chalazion clinically, but in an old age patient who comes with recurrent chalazion, with multiple history of incision and curettage, you should always keep sebaceous gland carcinoma in your mind. And upper lid, of course, sebaceous gland carcinoma is more common in the upper lid because the number of the meibomian glands in the upper lid is more. So, well, I thought she had undergone incision and curettage twice elsewhere. But the thing is, here again, there is not much of a large feeder vessel, although in the anterior lamella, there is one vessel sitting over here, and it almost appears cystic, right? So in this situation, although you know that it could be a chalazion, but there is a possibility of sebaceous gland carcinoma, whenever you do an incision and curettage, send the specimen for histopathology. Remember that you don't discard the specimen, just scoop out and throw it, but always send it for histopathology. And well, luckily this came out to be a chalazion. But even at this stage of my professional career, I'm extra cautious. I never throw off a tissue whenever there is a suspicion, even in an incision curettage for chalazion. So this is how typically a sebaceous gland carcinoma presents, yellow in color, very nodular. There is nothing to think about. And well, a complete excision was done with frozen section. What do you mean by frozen section is it's an intraoperative diagnosis. So we excise 4 millimeters from the side, from the clinically visible margin, 4 millimeters on either side, medially, laterally, inferiorly, and even posteriorly. And then immediately we send the specimen to the histopathologist. So like me in my practice, I don't have an a pathologist in my hospital. I send it to another hospital. So, but there is a little bit of an effort that you have to take. You arrange a pathologist wherever. If you have it in your own place, well and good. Otherwise, don't give up. Arrange in another, pathology lab where you are confident about the pathologist. Send it there and then get the report within 30 minutes. So we get it within 30 minutes. And what we look for is basically not the diagnosis, but whether the margins are negative or positive. And I would reconstruct it only if I get a report where it says that all the margins are negative. If by chance the report comes as well, the lateral margin is positive, what I would do is I would go back again and then take another 2 millimeters of the margin, send it, recheck it again, and once it comes negative, then we reconstruct. So again, reconstruction, there are various ways. I'm not going into the detail of reconstruction over here. What I did for this patient was I did a tensils from here, so releasing the lateral canthus and then, taking the flap more medially, and closure was almost possible. Because in older patients, mostly the lids are quite lax. It's not too difficult to reconstruct and oppose the tissue. And this is how she looks after a tensils procedure and closure of the eyelid. So once again, to revise, nodular ulcerative lesion, loss of eyelashes, loss of meibomian gland architecture, rounding of the posterior border, conjunctival congestion, blepharoconjunctivitis, always think of sebaceous gland carcinoma. And as I showed you before, this is how we mark it, clinically visible margin, even the posterior lamellae. We excise, and this was a huge flap of tarsoconjunctiva, which was brought down from the other side. And a skin graft was required in the margin. So I did a blepharoplasty and then took the skin graft and put it over there. And this is how she looks like after a frozen section margin control and Hughes flap from the upper tarsal conjunctiva and skin graft. Now I'm just going to go through a quick video over here, one of the lid excisions. So just, we will pass it through very, very quickly. So you assess the size on the table, size of the tumor, and the clinically visible margin, as I told you. So we mark 4 millimeters on either side. All right. And this is how the marking is done. All right. And also make sure that the posterior lamella marking is also done. It's not only the anterior, especially in sebaceous gland carcinoma, which arises from the posterior lamella. So the posterior lamella marking is also done. Traction sutures are taken so that, you excise it properly. And this is how we excise it all along the margin. Make sure the posterior margin is also well taken up. And it is, as you saw here, it is placed on a Rootman filter paper, which is very important. And this is how we send it to the pathologist. Okay, the lateral, L is lateral, medial is, M is medial, and I is inferior, so that the pathologist exactly know which margins they have to report. And it's very, very important to mark it and send. It came as if at all there is diffuseness in the lesion, an extra margin is also taken for the pathologist. So this is again, this is how a Tenzel's procedure is done, where, you know, a lateral canthoplasty, a lateral canthotomy, cantholysis is done. We separate the lateral canthus, and then a flap of the tissue is moved medially, so that you know, this can be joined with the skin, and this is the new lid margin which moves off medially. Although I knew that I would be sharing the tarsoconjunctiva from the upper lid, but I wanted the tarsoconjunctiva, what I am sharing from the upper lid, to be minimal and not the entire length. That's why I actually advanced this tissue medially. So this is how you do the Hughes flap, where you take a tarsoconjunctival flap from the upper lid. Upper lid, we all know that it's around 8 millimeters in height, the tarsus. So almost 4 millimeters you separate. And this is how the inferior tarsus is kept in position for the upper eyelid, and it is the superior 4 millimeters that is taken. A careful dissection without injuring the LPS too much. Don't go too deep, and this is brought down, where again it is a posterior lamella to posterior lamella apposition, and then it is closed. Well, we do remove the corneal shield at the end of the closure, and this is basically to protect the cornea, that your needle doesn't injure the cornea. And after closure, then, you know, if there is enough of skin available, especially in older patient, you can actually slide the flaps, you can, and then try to oppose it, or you can also use a skin graft. Now, so this is an occlusive procedure. So it also requires a second stage, where after 6 weeks, we open the occluded eyelid where the lid has been shed, and this is the second stage procedure where you open it, so you can have a very nice healthy conjunctiva where you can either suture it or glue it. So, well, that is one surgical procedure. There are like larger lesions. This was a case that I had seen with large recurrent BCC, where, you know, you have to, in fact, excise a large portion of the eyelid, and then you might have to use larger flaps, rotation flaps in these cases. This is the case that I showed you initially, a case of suspicious vegetoid spread of SGC, and this is how she presented, and very, very cautious about it. It's very difficult to treat also, because it's a very diffuse involvement of the conjunctiva and the eyelid. Now, this is what we do. This is called map biopsy, where you map out the different conjunctival spaces, including the perilimbal, bulbar, then you go to the fornix, then you go to the tarsus, both in the upper and the lower lid, and also we take it from the caruncle, and then this is presented to the pathologist in formalin, kept in this Rootman filter paper. You have to number all these things, so when it comes back, you know which number is positive, whether it's 1 positive, whether it's the 11th one positive or the 15th one positive. So that is how we surgically manage malignant tumors. And this is for you to know what is a recent advancement, sentinel lymph node biopsy. We have been talking about it for many, many years. There are institutes and places which strictly follow it. There is a little bit of controversy whether we should be doing it or not, but there are specific indications of sentinel lymph node biopsy. And what do we do is we go and inject, you know, isosulfan blue or technetium 99 into the conjunctival space, okay, around 0.2 ml is definitely enough. And then what you do is there is a gamma probe, so you handheld the gamma probe and then take to the area, the draining lymph node, and see whether there is any isotope uptake. If there is an uptake, then we go ahead operating, seeing and taking out all the lymph nodes, the draining lymph nodes, where there is a possibility of regional lymph node metastasis. So I want you to, you know, come and concentrate on this particular indications here, and this is the indication of sentinel lymph node biopsy, cutaneous eyelid melanomas of anything which is more than 1 millimeters in size. As I told you, it's a lethal eyelid malignancy. Sebaceous gland carcinoma, anything which is more than 10 millimeters in size, and Merkel cell carcinoma is the lethalest. So of any size of Merkel cell carcinoma, you have to look for a lymph node metastasis. Now, there are a few newer advancement. I don't have personal experience with these drugs. It is Vismodegib. It is, it's an hedgehog pathway inhibitor. And this is usually used in advanced basal cell carcinoma, especially, involving the orbit, very deep invasion where you kind of want to regress the tumor. Now, these are the reports initially regarding the outcome of Vismodegib. I have seen my mentor, Dr. Carol Shields, using it. So I have seen it being used because basal cell carcinoma is very common in the West. I don't have personal experience. So this is again an eyelid tumor, which is, bilaterally presenting. Well, you have been thinking of many things. It could be granuloma, but we don't go and excise the whole thing. The only thing that I did was to go and do an incision biopsy from the left lower lid, and it came out to be a small lymphocytic lymphoma. So there are cases where, again, rare systemic malignancy can also affect the eye and present like an eyelid tumor. So all these things should be kept in mind. So you have to identify and treat these lesions appropriately. Take all the lumps and bumps seriously, because this is why I wanted to highlight the common ones and the rare ones, because things can really surprise you. All right. And it's very important to identify the clinical features which differentiates a benign and inflammatory and a malignant eyelid lesion. If required, ancillary diagnostic tools, yes, even including, CT scan and MRI. Sonam has taken a wonderful, fantastic lecture on how you interpret a CT or an MRI, and especially in these eyelid lesions, when you feel that there could be a orbital invasion, it's large, the size is too large, then you go for it. Biopsy, yes, definitely for histopathological confirmation. And what I would want to stress here is anything which is oncology related, it's very, very important to follow oncological principles. As an oculoplastic surgeon, yes, I am concerned about cosmesis, but more than the cosmesis, what I will be concerned is I don't want the tumor to recur. I don't want the tumor to spread to the lymph nodes or metastasis and cause a mortality rate in that patient. So it's very important to undergo and follow strict oncological principles in that. And it's not difficult to reconstruct, however, bigger the defect is, because there are many transposition flaps, grafts, etc., which will take care of it. Thank you very much for your patient listening. And I hope I have not gone over your head for the postgraduates. And if you have any doubt, I'm very happy to answer. Thank you so much.
Okay. Thank you, Dr. Feroz. Such an elaborative lecture, very helpful to the postgraduates.
Thank you.
Small things, big things, small things and big things.
Things also, yes.
Routine things and the golden medal things. Yeah.
Yeah.
Thank you.
Any questions? No questions from the PGs. I hope they're not sleeping.
Lunchtime now, basically. And now most of you preparing for quiz next.
Oh, there is a quiz? Oh, nice. Are you the quiz master?
No, Dr. Thomas Arun and Dr. Shevin are the quiz masters.
Okay, so whenever Mariam goes for a quiz, she always wins it. She always wins it. I don't know whether there is a trick behind it, but she is like a quiz winner.
Thank you.
We had one together, Mariam. If you remember,
we had one together. Long time before,
Yeah, OPI quiz.
Recently there was the South Asia ophthalmology. That also she won.
She always wins.
Thank you.
So I always pick up Marian as my teammate to win it, actually.
And I remember that tip.
Thank you so much.
Thank you very much. Thank you for the excellent talk.
Thank you so much.
Okay, I couldn't take my eyes off for a second, just like that. Gripping.
Thank you, Dr. Shashi. Thank you so much.
Dr. Shebin, I think.
So let us go to the quiz program then. Can the participants introduce themselves once?
Some more to join, isn't it? Kanisha. Kanisha and Anisha. Anisha.
Anusha. Kanisha and Anusha.
Yeah, that's what I thought. Yeah, okay. And that's from Amrita. Then from Girdhar, we have Axial and Kirtana.
Yes,
Yeah?
sir.
Okay,
Yes,
okay. And then, so we have 4 teams for the quiz. Shebin, what?
Next team from Little Flower.
So
Rehana was there, no? Yeah. Sorry.
Rehana,
madam.
Yeah. Okay, you both are sitting together.
So,
Dr. Serene and Dr. Rehana, right?
Yes, ma'am.
from Dr. Serene and Dr. Rehana. That's from Little Flower.
Yes, sir.
Okay. And then from Tony's, we have Dr. Leia and Dr. Shebin. Yeah.
So team A is from Amrita, team B is from Girdhar High Hospital, and C is from Little Flower, and D is from Dr. Tony. Yeah. So shall we start the quiz then?
Yeah. So we have 4 teams for the quiz, as Dr. Shebin said, in alphabetical order from Amrita, Dr. Kanisha and Dr. Anusha, from Girdhar, Dr. Kirta and Dr. Afzal, from Little Flower, Dr. Sarin and Dr. Rehana, and from Dr. Tony's Multi-Specialty Eye Hospital, Dr. Leia and Dr. Sherry. Okay, Dr. Shebin will now explain the quiz rules.
Warm welcome to all the participants. So the rules are, there are 10 questions to each team. So there will be a total of 40 questions and 20 marks per question. Each will be having two parts. So each will be carrying like 10 marks each. If one team doesn't know the answer, if somebody else knows, it can be passed. But sorry, unfortunately, no marks. Okay. So shall we start?
Should we rename them? Should we rename them for
yeah,
better? Yeah, I think we will rename them. I will just rename them. Shireen from
LF.
Yeah. I am putting it as LF. Then Leia, Dr. Leia from Tony's.
Tony's, yeah, Leia and Shireen.
Yeah. Yeah.
Then Kanisha and Anusha from
Amrita Institute is already named. Kanisha, yeah, it's from Amrita.
Okay.
I put it as Ames, yeah. So now it's easy now.
Okay.
So A is Amrita, B is Girdhar Eye Institute, C is LF, D is Tony's. Correct?
Yeah. So we'll go in that order. So first A, B, C, D, and then from next round will be from B, C, D, A. We'll go like that. Okay. All the best.
So shall we start? We'll go to question number 1, team A. Name the orbital bonds. I hope you can see the picture.
Yes, ma'am.
Okay, yeah. So name the orbital bonds removed in 2-wall decompression.
Zygomatic lateral wall and medial wall are removed. In that lacrimal bone and maxillary bone, and along with that zygomatic part is also removed, and greater wing of spinard also.
Sir, kindly let me know if the time is over.
Yeah, and I think they've answered. You can say, Shireen.
Okay, so So you answered medial and lateral wall, right?
Yes, ma'am.
Okay, so let us see what is the answer. So in two-wall decompression, we usually remove medial wall, that is ethmoid bone, and floor maxillary bone. So it's partly correct. I think we can give them 10 marks.
Yeah. Okay.
Okay, so now team B. Question number 2. Identify the foramen and structures passing through.
Here is the right. Yeah.
Your orbital fissure. Structures passing through are
lacrimal nerve, frontal nerve, trochlear nerve, superior and inferior diffusion of
superior ophthalmic vein.
Yeah.
Okay, yeah.
Right.
So they have answered correctly.
Yeah.
Full mark, 20 mark. Now team C.
LF.
So question number 3 is enumerate the retractors and protractors of eyelid.
Retractors, orbicularis oculi, levator palpebrae, superioris.
Once again.
Orbicularis oculi.
No, which are the retractors?
Orbicularis oculi and levator palpebrae superioris.
Protractors? I think time is over.
Yeah, time is over.
So the answer is wrong. The retractors in the upper lid is levator palpebrae, Muller's muscle and frontalis, and lower lid is capsulopalpebral fascia and inferior tarsal muscle. So the protractor is orbicularis oculi. Okay. So next is question team D. Question number 4. Levator palpebrae superioris, origin and insertion. And 2 is question second part is total length and nerve supply.
Tony.
Above the annulus of Sim and inserted as an aponeurosis in the towards the upper lid. Total nerve supply is again third now. Total length is around 20 mm.
Carefully think and answer. The answer should be complete, not vague. You want to repeat the answer before the time is over?
It's inserted as an aponeurosis towards the upper lid. Now supply is again third.
So, actually answer is very much incomplete. Origin is above the annulus of Sim, but you have to tell it from where it is originating. Inferior surface of lesser wing or sphenoid. And insertion is upper lid. That everybody knows, but where exactly? So tarsus, it has attachment to the skin, the medial and lateral canthal tendons, and even to the through the MCT and LCT. It's also inserting into the posterior lacrimal crest, medially and into the Wittnall's tubercle laterally. And length is also wrong. It is 36 to 40 millimeter and tells superior division of oculomotor nerve. So, sir, should we give marks?
No marks.
Okay, yeah. So now we'll go to the second round. It will start with the team B. Team B, ready?
Yeah.
So question number 5, orbital septum. Where is the origin and where is the insertion?
Orbital septum origins from the from the superior from the orbital rims, and it gets inserted to the
louder.
With LPS muscle.
it inserts to the upper tarsal border.
Okay. So let us see the answer. So the first question is partially correct. Orbital rim, but from the periosteal condensation, that is arcus marginalis. And insertion is also partially correct. It is in, no, you told tarsus, right? Afzal told tarsus, right?
Yes.
Yeah.
Okay, it's not attached into the tarsus. It is attached into the levator, anterior surface of the upper neurosis, MCT, LCT, and even into the like medially into the lacrimal crest and Whitnall's tubercle. So I think
No marks.
5 marks or no marks?
No marks. No marks.
Okay. Question number next two teams C.
Yeah. LF.
What is the diagnosis and causative agent and also treatment? Any two treatment you can tell.
Pediculosis.
Causative agent.
Pediculosis.
Treatment.
You told the diagnosis, but causative agent and treatment.
Removal of the removal pediculosis.
Okay, let us go to the answer. So the correct name is Theriasis palpebrum. It's caused by the crab louse. Okay, and removal, it can be removed mechanically, application of petroleum jelly, permethrin shampoo, pyrethrin tea tree oil. So only partially inserts, sir. 5 or 10 marks can be given.
5 marks. 5
Okay.
marks. Right.
Now to team D.
Team D. Tony's.
Question number 7. Identify the condition and enumerate 2 management options. Arrow is pointed. You can see that.
Yeah, that's correct. How do you manage?
Again, epilation can be done. Epilation and electrolysis also can be done.
Okay. Full mark.
Yeah, full mark.
Now question to team A. Question number 8.
Amrita.
So what is A and B, and you can tell 2 causes for each.
Trichomegaly is A and scoliosis B. Trichomegaly can occur in post-prostaglandins treatment, and scoliosis in BKH syndromes also can be seen.
2 causes for each.
Oh. Leprosy also we can see in scoliosis, and trichomegaly can be seen in sorry,
Okay. So there are so many causes. It's given in all the textbook. So I think we can give 50 marks.
Yeah.
So now next round 2. So it will start
Team
with
C. Team C. LF.
C. Yeah. Question number 9. Identify and characteristic histopathology finding.
Molluscum contagiosum. Molluscum.
Yeah.
Next.
Molluscum contagiosum.
Yeah. Pathology.
Sorry, not what you are saying. Telling me.
Coronary bodies. Coronary H.
Time up.
Okay. So partially correct. Molluscum contagiosum. It is intracytoplasmic inclusion bodies, Henderson Patterson bodies. 10 marks.
10 marks. Yeah.
Now to D.
Team D. Yeah. Tony's.
What is the diagnosis and one systemic association?
Capillary hemangioma, systemic association, along with purpura, it can be associated.
Can you speak louder?
So this is capillary hemangioma, and the systemic association is it can be associated with the thrombocytopenic purpura, and that syndrome is known as
Okay, I think time is up.
Yeah.
So it's partially correct.
Yeah.
Capillary hemangioma and that thrombocytopenic purpura is Kasabach-Merritt syndrome, where the conception coagulopathy happens because of large vascular channels and platelets will be used up. And also it is associated with Faces syndrome. So 15 marks.
Okay.
Now team A.
Team A. Yeah.
Question number 11, diagnosis and enumerate 2 ocular features.
Sturge-Weber syndrome. And
yes.
Sturge-Weber syndrome with ocular features can be nevusum. Glaucoma can be there, and choroidal hemangioma.
Okay, so let us go to the answer. So full mark 20.
Okay.
Now team B.
Yeah.
Ready?
Yes, sir. Yeah.
Question number 12. What is the diagnosis and types?
Epiblephron diagnosis.
Oh, is that time is over?
Yeah, time up. Yeah.
Okay, so you told epiblephron, right? It is epicanthal folds. Types are epicanthalus inversus, tarsalis, supraciliaris, and palpebralis. So no marks, I guess. Okay. So we'll go to the next round. Now it start with the team D.
I just give a roundup of the marks, Shebin.
Yeah, sure, sir.
There is 3 rounds completed. Now Amrita is leading with 45 marks. Second is Tony's with 35 marks. Third is Girdhar with 20 marks, and fourth is LF with 15 marks. Okay. Now starting with team D.
D.
Yeah, Tony's. Yeah.
So what is the diagnosis, management, and the systemic association?
This is a Stevens-Johnson syndrome.
Louder.
Stevens-Johnson syndrome. Management, ma'am, conservative management. Systemic association. Immunoglobulins can be given, and systemic association.
I think time is up. Sorry, the answer is ectropion. Full thickness skin graft should be done, and it is associated with the congenital ichthyosis. The picture is actually very classic. Okay. So next is team A.
Yeah.
Question number 14. It's a video.
Marcus jaw winking phenomenon. It occurs due to the disinnervation between the lateral pterygoids and the with the oculomotor.
Which nerves? Between which nerves again?
Trigeminal and the oculomotor.
Okay. So the answer is correct. Full mark. Now to team B.
Yeah.
Question number 15. Identify the syndrome and management of the eyelid in figure A. Eyelid.
Golden hair syndrome. Upper lip coloboma can be managed by direct closure.
Okay.
Yeah.
So the answer is almost correct. It's golden hair. First, you have to freshen to form a wedge and close it directly. Okay. Full mark. Now to team C. Diagnosis and syndromic association.
Can
you say louder? Part two of the question.
If any other team wants to tell the answer. Okay, so the answer is partially correct. Cryptophthalmos, it is associated with the Fraser syndrome. Okay, Fraser syndrome is characterized by syntactily urogenital abnormalities and cryptophthalmos. So that is 10 marks. Now, next round, starting with team A.
Yeah.
What is the diagnosis and which is the affected gene?
Blepharophimosis. Affected gene is B2, yes.
CPS?
Which gene?
Any other team wants to answer? Okay, so let us see the answer. So BPS, first part is correct. Blepharophimosis, ptosis, epicanthus inverse, and the gene is FOXL2, 10 marks.
Okay.
Next to team B. What is the diagnosis and the most common associated lid tumor?
Xeroderma pigmentosa associated with squamous cell carcinoma.
Most common.
Basal cell carcinoma.
Who answered that? Same team only, right? Okay, yeah. So full marks. Next to team C. Question number 19. What is the clinical diagnosis? Characteristic immunohistochemistry stain used for the diagnosis.
Squamous cell sebaceous lung carcinoma.
Stain, immunohistochemistry stain.
S100.
Sorry?
S100.
No, characteristic immunohistochemistry stain. Okay. Anyone else wants to answer? So the answer is SGC, correct? Adipophilin. Okay. Now to so you told something?
10 marks, isn't it?
10 marks.
Yeah.
And next
Tony.
Question number 20. Give two differential diagnosis and mechanism of action of pembrolizumab.
It can be basal cell carcinoma.
Louder.
One, it can be basal cell carcinoma.
Its still voice is very feeble. Can you
Can't hear. Yeah. Can you speak up?
Differential diagnosis. One is basal cell carcinoma, and it can be a nevus also.
Part 2. Question part 2. Okay. Time up.
Anyone else?
It's an anti-VEGF.
Okay. So answer is like partially correct. It is melanoma and pigmented basal cell carcinoma. So pembrolizumab is a humanized monoclonal antibody. It is a PD-1 inhibitor, programmed cell death protein. It is used in melanoma. So, so 5 marks or 10 marks?
5 marks.
Next is
give 5 marks. 5 marks. Yeah.
Okay, sir. So next is team. Sir, next team is.
Next is Amrita.
Oh,
Team A. Team A, Amrita. Yeah.
Okay. Question number 21. Mechanism of action and it used in which condition?
Dr. Fairuz had shown this.
Yes. Basal cell carcinoma it is used. Immunoglobulin moderate.
Anyone else wants to answer? Yeah. So half 10 marks.
10 marks.
This is what happens when you sleep, okay?
To team B. Question number 22. Mechanism of action and used in which condition?
Mechanism of action is inhibitor of insulin-like growth factor 1 used in a thyroid eye disease.
Okay, so you listen to the class. 20 marks. Now to team C. What is GView and what is the content?
Didn't show the answer. It's going to 23 now. Okay.
Team C only, right?
Did you show the answer of 22? 22, you showed the answer? Yeah.
Yeah.
Okay.
Showed up.
Yeah. Okay.
This was full mark.
Full marks. Okay.
This is next to team C, question number 20.
Yeah.
Botox.
What is
Parabotulinum toxin A.
What?
Parabotulinum toxin A.
Okay, I think we can give full mark. Botulinum toxin, prabotulinum toxin A.
Okay.
Good.
Good.
Next is team D. Question number 24. So where will you use this and how to calculate the dose?
Again, Dr. Fairuz had shown this.
Louder.
Sebaceous gland carcinoma.
Okay, time up.
Anyone else wants to answer?
Lymphoma.
Okay. So it is used for sclerotherapy or for lymphangioma, and the dose is 0.5 international units per kilogram body weight. We have to reconstitute and inject. Okay.
No marks. No marks.
Now, next round starts with team B, right, sir?
Yeah. Dr. Fairuz has shown a case of a patient with lymphangioma she had treated with bleomycin.
Yeah, so lymphangioma is the most common indication, Dr. Thomas.
Yes.
My case that I showed was actually a varix.
Okay.
Varix is very difficult to treat by surgically, so it actually helps in this also. But for PG students, whenever you talk in your exams as indication, you have to talk about lymphangioma. In fact, you should say veno-lymphatic malformation. That is what lymphangioma is known as, according to the newer ISSVA classification. Veno-lymphatic malformation.
Thank you.
Thank you, ma'am.
Yeah.
So next is team B, right?
Yeah.
Identify and use. This is also shown in the class.
Yes.
Nozzle except thermometer. And then,
What again? Full name?
Nagel's exophthalmometer used in measuring proptosis.
Then after orbital wall decompression.
More specifically, you want to modify the answer?
When the lateral orbital rim is not there.
Okay. So full mark.
Yeah.
Now go to next is team C. Identify and indicate use.
Want to say something?
No.
Anyone else wants to answer? Actually, it's a picture. From the picture, you can tell the name. It's platinum, right? It's like a chain, platinum chain. And it's used for lid loading in facial nerve palsy. Sorry, no marks. Next is team D. Question number 27. Identify.
Yeah, team D.
And how
Tony's.
to identify and how to calculate the size to be used.
And this is an orbital implant. Orbital implant, it's the porous one. Size to be used is by calculating the axial length.
Size, can you repeat the answer? Size, how it is calculated?
Axial length.
Okay, so I think time is up. Partially correct. It is porous polyethylene, and size of the implant should be more specific. Axial length -2 in enucleation. In enucleation, you have to subtract 2, and in evisceration 1. Okay.
So
Yeah,
10
so
marks?
10, yeah, 10 marks.
Okay.
Next is
Team A.
Team A. What is the instrument shown in the figure and used in which surgery?
This is used in Frontalis Sling surgery. The instrument.
Okay.
Time up.
Yeah. Anybody else wants to answer? So the answer is Wright's needle. It is used in Frontalis Sling surgery. 10 marks.
Okay.
Next is Team C. Next round starting. Identify and what is the use? Team C. Sorry, I think it's the Team B. Sorry for the mistake.
Ma'am, Ptosis clamp used for conjunctival molar rectum.
Actually, it should be for Team D, Dr.
Yeah.
D. Tony's to answer, isn't it?
But now it's already answered,
Okay,
right?
Okay.
So next question, Team B can answer.
So what's give the full answer?
No.
No.
Kirtana, you want to modify the answer?
No.
Okay, fine. So, Putterman's clamp used in Muller's muscle conjunctival resection. So you told Mullerectomy, right?
Yeah.
So I think 10 marks. Yeah.
10 marks. Okay.
So now
Shebin, they said clamp, says Shebin, give them 5 marks extra. You didn't get Puttermans. I think 5 you should give them extra.
Okay.
So 15, yeah?
Yeah.
Okay. The next question to Tony's.
No, sir, B didn't answer, right?
No, this was B.
Okay.
Yeah.
Okay, yeah. So now it is to
Tony's.
Okay.
D for doctor. Team D.
Okay, yeah. So question number 30. Identify and what is the use?
Time up. Okay, you can answer again. You want to answer? Tony's?
Pass, sir, pass.
Anyone else wants to answer? So it is a balloon inflation device and the catheter. So this is used in balloon dichrosis to rhinostrom. Okay, fine. Yeah. So next team is?
A, Amrita.
Okay. Yeah. So there are 3 pictures to identify one procedure. And can you tell one indication for the same?
MRA, it's fine. MR venogram. For
three pictures. Don't see one picture and tell the answer. Three pictures to identify one procedure.
So
what is the procedure they're showing here? And
venous sinus thrombus is there in the reducing of thrombus.
Okay, I think time is up. Anybody else? Okay, so this first picture shows some kind of this is a digital subtraction angiography. It shows some kind of a vascular lesion, right? And in the second picture, you can see some cannulas going into that lesion. And third picture is what? It is N-butyl cyanoacrylate glue. So it is endovascular embolization, and it can be used in arteriovenous malformations. So marks, I think, no mark. Okay, next is team B.
Team C, LF.
Okay,
team C. LF next.
So 32, what is the diagnosis and systemic association?
Meningioma. Optic nerve meningioma.
Who is answering? Don't tell option. One answer.
Optic nerve glioma and neurofibromatosis.
Oh, neurofibromatosis, 1 or 2? Most common?
Type 1. Most common type 1.
Okay. So optic nerve glioma, neurofibromatosis, type 1. Here you cannot see the optic nerve separately, right? So if you see the optic nerve separately, then you can think in terms of meningioma. So this is an enlargement of optic nerve, so glioma. So full mark. So next will be team D, right, sir?
Next will be team D. Now team A again. Team A. I'll just give a roundup of the marks. We completed 8 rounds. So Giridhar is leading with 115 points, closely followed by Amrita, 95, LF with 75, and Tony is with 45. Okay, last 2 rounds. Now team A, Amrita.
21-year-old male presented with sudden onset drooping of the left upper eyelid and swelling of minimal swelling of 1 week duration. So the imaging is given, diagnosis and management. Again, shown in the class.
Cystic the cystic parasitic cyst. Management. Albendazole, systemic albendazoles.
Time up.
Okay, so almost partially correct.
Yeah.
Cysticercosis, you can see the scolex inside, right? LPS, and the muscle also you have to tell. And the management is albendazole oral and along with oral prednisolone to reduce the inflammation. So dose is oral albendazole is given 15 milligram per kilogram body weight per day in 2 divided dose for 4 weeks. It is not like a single dose or 2 dose and 2 weeks apart. It has to be given for 4 weeks, and oral prednisolone 1 milligram per kilogram body weight tapering course. So I think we can give them 10 or 15 marks, sir.
15. Give 15.
Okay. So next is
B. Get that.
okay. So question number 34. 7-year-old female presented with the right eye proptosis of 2 weeks duration. What is the clinical diagnosis? And the imaging pictures are also shown. What is the clinical diagnosis, most probable, and management?
Rhabdomyosarcoma, systemic chemotherapy, and any accentration with
Time up.
Fast answer, fast management, but then, okay. So rhabdomyosarcoma, just do an incisional biopsy. Who will accentrate? And then chemotherapy. Okay. So whatever be the proptosis for accentrating, we should think twice. Okay.
Shebin, chemotherapy and followed by radiotherapy.
Radiotherapy. Okay. Yeah. Thank you.
10 marks.
Oh, okay.
Team C. Next, Team C, LF.
Yeah. Question number 35. Diagnosis and indication for surgery.
Floor fracture, teardrop side.
Okay. Indication, you can tell 2 indication for surgery.
Enophthalmosis. Enophthalmos.
Okay.
Diplopia.
Okay. So enophthalmos, how much? More than 2 millimeters.
More than 2 millimeters. Yeah.
Diplopia in functional gaze. There are other indications also with the large fracture involving more than 50% of the floor area. And as Dr. Sonam already showed, and there is a white-head broad fracture muscle causing vasovagal attacks also. Yeah. Next is
20 marks.
yeah, full mark.
Full
Yes,
marks. Yeah. Team D, Tony's.
Okay. Question number 36. Diagnosis and enumerate 2 associated orbital manifestations.
Dactylitis, orbital manifestations, mechanical ptosis,
See, just examine carefully the picture once again. Okay, fine. Anyone else wants to answer?
Plexiform neurofibroma.
Okay, who is answering? The other team, right?
Sphenoid wing dysplasia. Sphenoid wing dysplasia.
Okay, so who answered this question right now?
And C, team C.
Okay. Not the one I asked, right? Okay. So it is a plexiform neurofibroma and associations, orbital, there are many associations, ocular, systemic, but orbital associations are optic pathway gliomas and absence or dysplasia of the greater wing of sphenoid. So I think the asked team, they didn't answer, right?
No, they didn't answer. No marks.
Okay, yeah, no marks.
Coming to the last round.
Now question number 37. What is the diagnosis and associated nasal pathology that can, sorry for the spelling mistake, that can cause respiratory distress?
Team B. One question to Team B. Get to that. Say something. Okay, time out.
The answer is the acroseal, or if it's in a newborn baby, amniotocoel also. The containing fluid could be amniotic fluid also, and so this can be associated with intranasal cyst. So that can cause respiratory distress in the child. Yeah. So no mark. Next is as a team.
Team C, LF.
Diagnosis and options.
Madam, slide.
You can see the slide?
No.
What about others?
Okay.
I can see.
Okay.
Retinoblastoma. White eye reflex.
Carefully examine the picture once again. Anyone else wants to give a try? Sorry? Okay. I don't know if it is that confusing. So the answer is that is an exposed orbital implant, PMMA. That is why that clear transparent sphere you can see, right? It is almost more than 50% exposed. So in these cases, better to remove the implant and later do a secondary reconstruction, preferably dermis fat graft or a repeat wall implant. So no marks.
Next to team D, Tony's. Second last question. Yeah.
Yeah, question number 39. So what is the historical picture depicted in the figure? And what is the preferred procedure in a painful blind eye with unknown etiology, and why?
The exception.
Louder.
Exception.
Okay.
Evisceration is the preferred procedure.
Why? So, didn't listen to Dr. Akshay's class? Okay, fine. So, first answer is correct, extirpation, but we should prefer in this cases enucleation. He already explained, right? So, it is a painful blind eye. We don't know the etiology. So, the rare cause could be an intraocular malignancy. So, we need full eyeball specimen for detailed histopathological evaluation, and also doesn't want to spread the malignancy. Okay. So, next is sir, team.
10 marks, sir. 10 marks.
No, they told evisceration. Yeah,
Okay.
10 marks. Yes, 10 marks.
Yeah. Okay. Last team A, Amrita.
Okay, so 74-year-old lady presented with right eye redness and mild pain for past 6 months. So what is the diagnosis and management?
Superior ophthalmic vein. Ophthalmic vein dilatation. Thrombosis. Sorry.
Who is telling the answer? Can you be clear? What is the diagnosis?
Superior ophthalmic vein dilatation. Okay. Secondly to the thrombus, cavernous sinus thrombus. Management, thrombolytics can be given. And because of any squint that is residual of thrombolytics can be given, and
okay.
Exposure keratopathy can also be there. So lubricants and tarsorrhaphy can also be there.
Okay, I don't know why you didn't tell caroticocavernous fistula. So the management is, if it is, it can either be managed with intermittent manual carotid compression, or if not, endovascular embolization with coils or glue. Okay. So, sir.
Yeah.
Yeah.
It's over now. Okay, thank you. Thank you all for the active participation. And thank you, Shebin, for the wonderful questions. It's a nice learning experience for me as well. Okay, I'll just say the points. So the winner is Girdhar Eye Institute with 135, and closely followed by Amrita 125 and LF 115. Okay, thank you.
Okay, so congratulations to the winners. Sorry, we don't have any prize. Okay.
We will give an unofficial prize to them.
Yeah, yeah.
Ophthalmic club. What about Dr. Arun?
Yes, definitely. Definitely. Yeah. Okay.
Okay, so shall we go to the instrument corner?
Yeah, I thank actually all the PGs who participated. We have put this quiz just to stimulate you to read more. So any experiences from can you tell Dr. Kanisha and Anisha, what are your experiences regarding the quiz? Like 30 seconds. Yeah, this running short of time. Do you think this quiz stimulates you to read more?
Yes.
Yeah, so that was the aim of this quiz actually. That is why it's like everybody should read more.
Dr. Fairuz, your comments?
Yeah.
Yeah, well, congratulations to the winners. They were all really, really good. And I'm also elated to see all the girls as the...
No, one boy is there.
One boy. I was so happy inside. Anyways, yeah. And yes, the questions, I also learned a few new things. Yeah. Excellent, Marin and Shebin. Happy to be there.
Thank you, ma'am. Thank you for correcting some answers.
Bye.
Yeah, I think we'll... Any comments from Team Giridhar, Team Tawnis, and Team LF? Because you are our COC, Cochin Ophthalmic Club postgraduates. So our aim is to win KSOS TACO quiz by Cochin Ophthalmic Club in 2022 KSOS. Hope we will see what will happen.
Marin, you have to give training. You have to tell them the name.
Yeah. No, we are planning bi-monthly or monthly quiz programs, so that you will read more.
Yeah, yes. Okay. All right. Bye. I'll take leave everyone.
Yeah. Thank you, Dr. Fairuz, for the comments and suggestions. Thank you.
Yeah,
for staying for the quiz as well. Thank you very much. And for the excellent talk. Thank you. Thank you.
Yeah. I'll just share my screen. Yeah. So now we have come to the last part of this Super Sunday. This is the instrument corner. This is basically the summary of what we have learned in the morning. So I'm not elaborating too much. I'm just familiarizing you the various instruments that can be kept for the exam. So first is Nettleschicks punctum dilator. So this you cannot miss in any of the exams. It's very classical. The questions that can be asked from this side is what is the use? So in punctus stenosis, we can dilate the punctum. Then in probing, it is used. Probing syringe. Next is Bowman's lacrimal probe. So here we can have various sizes. The examiner might ask you where exactly the size has been written. So sorry, in this it is not clearly seen, but the size is written here. Based on this, you can get questions on probing. So I'll just show a small video. What is the indication for probing? It is congenital nasal lacrimal duct obstruction at 1 year when the lacrimal massage is failed. This is a short video, the steps of probing. Sorry, I think video is coming. Only the music. Yeah, only the music is coming, I think. Okay, no problem. First, dilate the punctum, dilate the upper punctum, then do the syringing, confirm the diagnosis as NLDO. Second, you just straighten the canaliculus and insert the probe. Once it touches the bone, you mean it is bony obstruction. Then we advance downwards, medially and backwards along the direction of NLD. See the video. No, the video is not coming. Okay, and confirm the patency by syringing. We prefer upper punctum. Why? Because too much manipulation of the lower punctum can cause fungal stenosis also. So probing is done through upper punctum, and after the procedure, you can do syringing even through the lower punctum. What is the size of the probe? There is some examiners might ask you, like 000, it can be used in neonates. 00s can be used in less than 3 months. 00 used in 3 months to 1 year, and probe size 1 is used in more than 1 year. This is a favorite question of some of the examiners. Then the direction of the probe. See, downwards and medially. Then you should know the whole anatomy of the nasolacrimal drainage system before going for the exam. So now come to the DCR instruments, diagnosis-to-rhinostomy. So this is Carisen Ronger forceps. Here also they might ask you where the size is written. Here also the size is written, like 0.5, 1, 2, 1.5, 2.5, 3, all those things. I'll just go through the instruments one. This is Carisen Ronger forceps to punch the bone. Now look at the periosteal elevator. Just see the tip. This tip and this tip. This is pure periosteal elevator to lift the periosteum during DCR. This is another one, trapezius periosteal elevator. Look at the edges. These are L-shaped. This we use basically to retract the nasal mucosa after the bone punch, so that we will not injure the nasal mucosa during DCR. One more thing I will show you. This is lacrimal sac dissector. So this is the flat end and this is the sharp end. So I have put these three together. This is a very, like, during my PG days, it's very confusing. So, but when you think about the use, it is very easy. So this sharp edge to reflect the periosteum. These two are blunt. L is after punching, you have to insert this edge so that the nasal mucosa will be retracted medially, and further punching will not give any injury to nasal mucosa. And this is to dissect the lacrimal sac of the lacrimal sac fossa. A small video of DCR. So DCR, you should know what are the indications, contraindications. Indications: chronic diacrocystitis, absolute contraindications, tuberculosis of the nasal mucosa, then lacrimal sac tumors. Related contraindications can be cicatrizing diseases like Stevens-Johnson syndrome, OCP, etc. Then steps. So first is incision. We prefer infraorbital, along the infraorbital groove. After marking, you can give the block. DCR anesthesia also is an examiner's favorite question. First is infraorbital block, and second is infratrochlear block. So infraorbital block at the junction of medial 1/3 and lateral 2/3, 10 millimeter below the inferior orbital rib. This anatomical landmark. This is the infratrochlear block just above the medial canthal tendon, directed medially. After these two, we can give medial peribulbar block also. This is just an addition, need not be really necessary. But classical blocks are first 1 and 2. So when the nasal packing is done, first put lignocaine spray, then use nasal speculum, pack the middle meatus, pack along the floor of the nose. Coming to the steps, incision is with number 15 blade along the infraorbital rim or infraorbital groove. Blunt dissection done, reflecting the orbicularis. Then incise the periosteum. Either you can use cautery or a blade. Now reflect the periosteum. Separate the lacrimal sac from the fossa by blunt dissection. Lacrimal bone is fractured. Make sure no injury to the nasal mucosa. Osteotomy is done. You can see the nasal mucosa reflecting. Lacrimal sac is identified, nasal mucosa identified. Infiltrate the nasal mucosa to reduce bleeding. Now punctum dilated, probe is inserted. Note the indentation of the medial wall of the sac. Make the lacrimal sac flap in a T-shaped incision. Horizontal part of the T. Anterior flap and posterior flap is made. Anterior flap is secured with, sorry, it's a H-shaped incision. Yeah. Anterior flap is secured. Posterior flap is excised. In pediatric DCR, we will not excise. We will suture the posterior flap. After excision, just look for any abnormality in the nasal mucosa. If any doubt, send the sac for the histopathology. Similar incision is done in the nasal mucosa and anterior flap and posterior flap. Anterior flap is this. Posterior flap is excised. Now suture the flap. So I'll just stop the video with this. So questions asked, what is the size of the ostium? It is 10 to 12 millimeters. Why? Because the vertical height of the lacrimal sac is around 10 millimeters. Then what are the boundaries of the ostium? Anteriorly, till the punch cannot be inserted between the bone and the nasal mucosa. Posteriorly, till removal of aerated ethmoid. Superiorly, till 2 millimeter above medial canthus. Inferiorly, till the nasolacrimal canal is partially derived. So these are the questions which they usually ask. This is just to show the lacrimal sac fossa. Anteriorly, it is formed by anterior lacrimal crest, posteriorly by posterior lacrimal crest. So these are the things about DCR. Now we'll come to the botulinum toxin. Also favorite question. When they keep this, usually they ask mechanism of action, indications. Indications broadly divided into functional, aesthetic. Functional, again divided into dystonias, then dry eye, chemotarseraphy, Ectropion, and lacrimal. Dystonias, blepharospasm, hemifacial spasm, apraxia, myopenia, Mead syndrome, etc. Coming to the retractors, this is a CAT scope looking at the forked edge. You know, this is CAT scope retractor. This is Desmaris retractor. Desmaris is usually to retract the lid during all surgeries. We have seen all the surgeries in the morning, Ectropion, Ptosis, etc. This is to retract during DCR surgery. Ptosis clump we have already seen in the Putterman's clump we have seen in the quiz. With this, they can ask you about all the ptosis surgeries. It is used in Muller's muscle resection. This is Burki's ptosis clamp, which we hardly use nowadays. Let's look at the difference. So this is serrated. This is the serration is little different here. Here also to grasp or clamp the levator tendon between molars and superior tarsus. Some senior examiners can ask you this, Burki's ptosis clamp. Coming to Calazion clamp, this instrument is familiar to everybody, but questions based on this, we have heard from Dr. Feruz. So what is Calazion? It is a lipogranulomatous inflammation of the meibomian gland, various incisions, hordeolum internum, vertical, externum horizontal, and cruciate incisions are also being used. Then they will ask you what are the signs of late malignancy, which we have already heard from the class. Another one is Ectropion forceps. This is also, there are right side and left side. I hardly use this, but in one of those last BNB exam, it was asked. This is an Ectropion forceps or Ectropion clamp. So they will ask about different Ectropion surgeries. Now, very important instrument. This is enucleation spoon. So look at this slot. This is to engage the optic nerve during enucleation. Now I will show you another spoon. This is evisceration spoon. So how will you differentiate between the two? So when two things are kept, this is big because and there is a slot. This is small. Evisceration spoon is to scoop the uveal contents during evisceration. With this, they can ask you about the indications of enucleation, evisceration, steps, etc. So now coming to the various silicon things in oculoplasty. One is lacrimal intubation set. So there is a metal rod here with a silicon wire. This is Frontalis suspension set. Here also there is a metal and a silicon. But how will you differentiate? Here the metal edge will be sharp. It's a needle. It's a needle attached to it. And you can see a sleeve in the Frontalis suspension set. Second thing, lacrimal intubation set is 23 gauge and Frontalis is 20 gauge. That is little more thicker. So these are the, when you see both together, you'll get a confusion. Is this Frontalis suspension set or lacrimal intubation set? So the key point is Frontalis suspension set will have a needle to pass through the skin during surgeries. So with this, different questions can be asked. The third one is mini monoca stent. Is used in canalicular tear repairs. Again, silicone fingering. Implants, we have already seen and heard from Dr. Akshay. So don't make any mistakes. Like this is acrylic PMMA implant and this is Medcore implant. So one is white and one is transparent. With this, again, they will ask you all the socket surgeries, enucleation, etc. So these are the few things few instruments which I want to discuss in this. Thank you. Any questions you can ask or you can put in YouTube chat box.
It's a very nice roundup of instruments.
Yeah.
Yeah.
Thank you.
I used to have this Ectropion for upper lid, lower lid, left side, right side. All that is out now. Huh? Okay.
I never use Ectropion clamp. Dr. Sujit, you use Ectropion clamp? No.
Okay. Yeah. Okay.
So
good.
Yeah, we have almost come to the.
Yeah, that is a very good. Excellent
Excellent
talks. Then covered all subjects, all aspects.
Yes.
Yeah.
90% of plastic is covered.
Covered. Yeah. A nice
quiz
also.
Yeah, I think with this we have come to the end of the session. I thank all the faculty members who have taken the time and found a Sunday to spend time with us. Yes, sir. Yeah.
Yeah. Thank you. The session was excellent. I've sat through all the session, although I was hiding behind. See, you were leading, and the classes were excellent. This is what the PGs want.
Yeah.
Postgraduates, they don't want a detailed, in-depth lecture on anything. But as you said, what is the commonest thing? What is a common questions asked? Like that. So such sessions will benefit the postgraduates. And I hope the entire postgraduates of Cochin have watched this. Otherwise, they should watch it. It is in the YouTube. And what we plan is we had a discussion in the sidelines with Dr. Marian. So what we are planning is that we should have a postgraduate group. So actually, this planning, the topics, the timing, all these should be planned by the postgraduates, not by us. What we can do is that we can provide faculty. We can provide excellent videos or whatever they want. But the planning should come from the postgraduates. Just like in the school classes and the college, we should have a leader. That the leader will they will discuss with their fellows, the postgraduates and the residents, and then let them say we would like to have a class on this topic, so that we can help them. It is rather than we arranging them for the postgraduates, because we don't know what they want. Yeah. So let the postgraduates do the planning and we will do the execution. So like that, I think I don't.
One PG group is there.
Yeah, I think we should involve them in
the. One group passed out. Was there. We used to discuss, and previously we were having the meeting in each institute.
Yeah.
Okay. No, we can activate that also. Maybe this Wednesday, please arrange a meeting in the evening of the COC core group, because we have to plan for the future months and for the August ophthalmic, all those things we'll plan well ahead. And regarding the PG group also. So before that, if we can get the names and the phone numbers of all the PGs, maybe we can select a person from that and then let them plan them, because right now KSO is also planning so many PG activities. So we will have at least a limited number of the Super Sundays, and then we will have a case discussion or a didactic session or something of about 1 hour or 2 hours in the evening. And those topics, let them decide what topic they want. We will provide the faculty and we will provide the other technical know-how. So then it will be useful for them, because otherwise they won't be interested.
Yeah.
So if they want a case discussion on a particular disease, we will have that. So maybe Wednesday we can plan all those things, and then we'll go. Yeah. Thank you for thank you all the faculty and all the postgraduates who have participated in the quiz, and thank you Dr. Marian and Dr. Arun for arranging such a wonderful program.
Yes. And Shebin as well. Thank you very much.
Shebin has done most of the work.
Yeah.
Okay. Are we still online?